I saw that. I mentioned it to them and said, oh, it comes with that.
Well, that's the only way, but all of a sudden this morning I woke up and thought, I didn't specify.
Yeah, you did, you told me.
Okay, well, I appreciate your being on it.
Hello.
So it needs to be loaded on that computer there, or I think we run off the USB theoretically.
No, put it on the computer.
Yeah, well, Bill's messing with it though.
Yeah, our neighbors,
We'll wait.
Now,
we got like a fire.
somebody who's really like good with PCs would probably be quicker. Do we want to just load these on this computer so
Yeah.
we get all of them? Okay.
Theoretically, you want to copy
So,
and put it as boom, desktop.
okay, here.
Oh my gosh, we ran out of.
Well,
Okay, I just hit file. Why don't you
I was
take
actually
take
stressed
it from
out.
the
I was like,
USB
we
drive
have to turn our
and
lights
throw it
on.
up
There's
and
too many kids. But we didn't have a lot.
So what you want to do is open it and
It's
then
actually
save
It's
really
open,
as.
it's open in the background, so
But
I
it was
just
fun. I
hit
think
file, which
I don't know
hit back, I
where
guess.
you live.
Well, you want to just do save as.
Okay. Like our neighborhood, all the houses are super close together. We
And
had
then
like 20 houses in one street.
once you
So
go
there were people, I think they
to,
drove into the neighborhood to just walk
this
around.
PC,
Some of the surrounding houses have.
I'm glad you're at it, 'cause
where's the desktop?
Dr. Bernard is coffee. I got you, oh, hey, Dr. Bernard, I got you one.
Yeah, give it desktop.
Okay, if I just save it, then,
Now theoretically, it'll show up on the desktop.
okay, so
So close there,
close where?
close,
Here?
and then this guy,
This one.
Yeah.
Close the whole program.
and then it should be there on the desktop.
Oh, okay.
You want to cut off today? Well, I'm like,
So
I'm
just
stressed out.
get rid of that, I guess.
Oh, that's my
Okay, now
Justin.
you can put.
Justin,
Can
I'll
I just
Google
pull it or do I have to
search
eject
for me
it?
on
So
the
this
side.
is the way.
People ask me neuro questions.
Go to here.
Shower curtains.
Did you get your
That may be
tattoos
on
off?
Screen.
Oh,
I
okay.
still have like
Oh,
all
that's
this
a problem.
grimy stuff on my arm.
Okay, there it is.
I feel like a pumice stone. I was like scraping my arm.
Go to.
I just kind of couldn't. It's funny. It was hard to look at. So we had a Tiger King. We had a Joe Exotic.
Cool.
It was Joe Exotic. He had a shirt on. And he had a baby tiger. Thank you. And the
Go to
mom
my
was a
computer, it should be first.
Carol
Maybe.
Baskin.
Let's see.
Here's the, yeah, he's.
Oh,
Yeah, try clicking on that guy there.
Turn off, isn't it?
No.
Hey, does anybody know how to eject a drive?
Oh, yeah. Sure, sorry. My hands are going.
Oh, maybe it's down over here.
It's down at the
Now, do I advance? You're muted. Okay. Can you hear me, Justin? I hear myself delay, which is going to be really obnoxious. Weird.
You're on.
Hi, good morning. Welcome everybody to our first Zoom continuing education event. Sorry, we're a few minutes late. For every Zoom meeting, there has to be a few technical difficulties, but I think we got them all worked out. Hopefully everybody can hear me well. So just wanted to give a welcome. We appreciate everybody taking the time to spend their Sunday morning with us. As everybody knows, we're the Eye Care Center of Northern Colorado. Welcome to our event. Our group consists of the Eye Care Center as well as Advanced Vision Surgery Center. And just wanted to give a quick introduction. Who's ever?
Sorry, I'm trying to.
This is an introduction to our retina team made up of Dr. Benedict, Dr. Tilton, Dr. Canoff, and Dr. Manry. Our glaucoma and cataract team made up of Dr. Rothstein, Dr. Sheff, and Dr. Parikh. Our oculoplastics and cataract service, Dr. Myers, as well as our cornea and cataract service, Dr. Werner. Then we also have our two excellent primary eye care providers, Dr. Crone and Dr. Wolfert. Our team is also made up of the Advanced Vision Surgery Center. It's dedicated exclusively to ocular surgery and lasers, state-of-the-art design and equipment, and really helps us take excellent care of patients. As most of you know, we have 4 locations to serve you and your patients in Longmont, Boulder, Lafayette, and Greeley. And you can always visit our website for more information. So without further ado, our first presentation is going to be by Dr. Benedict, and he is going to be doing interpretation of OCTs of the retina.
Ready?
Yeah. So.
We're getting there. All right.
We have to share your screen.
Oh, one more step. We're almost there.
Okay.
All right. Jane, can you see it? All right, I think we're good to go. All right, well, some of you may recognize this talk. I've changed it a little bit. This was given a number of years ago, but when we surveyed everybody and tried to see what people were interested in hearing again, we had quite a few requests for a little more on OCT interpretation. Well, so what we're going to talk about today, we're going to talk a little bit about OCT imagery and anatomic correlation between the OCT and the actual retina. And we're going to try to understand the ellipsoid sign. I will tell you guys, there's about a half-second delay between what I say and what I hear in this microphone. Maybe that's better. Anyway, then we're going to talk about some pathologic correlations, and we're going to look at a number of different disorders. So as most of you know, we have high resolution cross-sectional images. In fact, we're going to just get rid of the headset completely there. Anyway, OCT is a high resolution cross-sectional image of the posterior pole. We can also image the optic nerve in the anterior segment. We can almost image the entire retina at this point in time. There are many advantages of OCT. It's non-invasive, non-contact, non-mydriatic. There's no radiation. It's painless, fast, reliable, reproducible, and it's extremely sensitive down to 10 microns. Now, we've gone through several generations of OCT. First was spectral domain. I don't know if any of you remember that. I can see the top image. This was time domain, I'm sorry. The top image, you can see it's a fairly low resolution image, but it was still helpful. We could see edema, we could see epiretinal membranes. It was good for VEGF inhibitor injections because we could see subretinal fluid. But we've moved on now to time domain, which is significantly higher resolution. And you can see that we have a very, very nice view of the layers of the retina. If you're interested in the difference, there it is. I will send you the slide if you want it. So anyway, spectral domain uses a Fourier transfer, which is similar to swept source. Swept source, if you've been hearing about this, this is the new version of OCT. It is much better at imaging the vitreous and the choroid. You can see the choroidal scleral junction. It doesn't have quite as good of axial resolution as spectral domain. So we'll see if it actually takes over. It does have an advantage that it is simpler to make and may ultimately be cheaper. So here's kind of the crux of OCT. OCT is really easy to interpret if you understand exactly what you're seeing on an OCT image and you know the pathology. So it's very, very straightforward. You can figure most things out just with a little logic if you know this. So starting at the inner layer, we can see the nerve fiber layer, the ganglion cells. You move on down and you have the ganglion cell layer, which are the cell bodies of the ganglion cells. The glaucoma specialists like this layer quite a bit. And the OCT for glaucoma actually gives nice ganglion cell layer images. Then moving down, you've got the inner plexiform layer. This is the synaptic layer between the amacrine, horizontal, and bipolar cells with the ganglion cells. Internuclear, that's the cell bodies of the cells I just mentioned. Outer plexiform, again, synaptic junctions. And then we get into the photoreceptor layer. So outer nuclear layer is mostly the cell bodies. And then we're going to talk a little bit more about the external limiting membrane. This layer right here, which has changed names. It's no longer the ISOS junction. And then down to the retinal pigment epithelium. A little more detail here. These become very important. We spend a lot of time looking at these inner layers because they represent the health of the photoreceptor. So often you'll wonder why a patient's not seeing well. And if you look very careful at these layers right here in the fovea, you'll have your answer. So the external limiting membrane is, as you see here, the junctional complex between Mueller cells and the photoreceptors. It's a structural layer. It needs to be intact. If it's missing, it means there's a photoreceptor problem. Moving on next to the ellipsoid zone. We'll talk a little more about that. But this one, we spent a lot of time looking at the ellipsoid zone. The ellipsoid zone represents photoreceptor health. If it's missing or irregular, it means there's something wrong with your photoreceptors. This right here, COST, C-O-S-T, is the posterior tips of the cone outer segments. That's this little line right here. It kind of disappears in a lot of people that are older. You see this a lot in younger people. And then the final layer right here is thought to be RPE versus Bruch's membrane. All right, a little more anatomy. This is looking at the ellipsoid zone. If you look at a photoreceptor over here in image C, you can see the cell body. You can see the inner segments from here to here. And they've got the myoid zone and the ellipsoid zone. And then move down here, you can see where the photoreceptor discs start. It used to be thought that that line was this junction here, but it turns out it's this cluster of mitochondria in here that gives that highly reflective line. Now, Just different types of scans that you use in your office and you want to look at. I use the standard grid quite often. I like that a lot for macular degeneration. It covers the central retina. It gives you two nice vertical and horizontal slices right through the fovea. And that's a good general screening test, but you can see it misses sections up here in the 4 quadrants. The raster, that's a very useful tool. If you ask Dr. Canoff, he'll tell you that's the only tool you need. He loves the raster. I like the raster in particular for things like diabetes, because you cover, if you look at the image down on the lower left, you cover the entire retina, but you get a nice broad view of everything. And then if you look at the radial, I love the radial when I see foveal pathology, because you slice that, many, many different ways all through the fovea. And it's not infrequent that you'll think there's not a macular hole, but there is if you run the radial scan. All right, then there's the high resolution scans that you can run. These are not technically any higher resolution than the actual scans you're getting normally. This uses computer software, and if you look down here, this is an average of 80 separate scans that are put together to give you a nice high resolution scan. And these look to me quite a bit like swept source. You get better choroidal definition. You can see better vitreous definition. Now, I will tell you one thing I don't like about Zoom is I like it when people interject and ask questions. And now I would ask if you had questions, but I don't think there's a way I can answer them at the moment. So anyway, we're going to get on to pathologic correlations. Some of you know I like throwing photographs in. This was last fall on the Grand Mesa in the western part of our state. So, going back to some of our anatomy that we just learned, when you look at macular holes, we go here through all the layers. So this layer right here, you can see is contiguous, goes right across. That's the retinal pigment epithelium. So you have intact retinal pigment epithelium. You look at your ellipsoid zone, it comes along and it terminates right there. Then it picks up again over here. And then this is obviously a full thickness section of missing tissue. And typically in holes, you have some cystic changes. This is an older hole, a fresher hole. There'll be a little more puffiness and more cystic changes at the edge. If we move on to a stage 1 macular hole, again, going back to the anatomy, if you look right here, you have intact retinal pigment epithelium going all the way across. You follow the ellipsoid zone, it goes right up and over, the external limiting membrane right up and over, and that's all intact. A little bit of epiretinal membrane, and here too you can see the posterior surface of the vitreous. So this is a stage 1 macular hole until you get a radial scan. So here's an example of how radial scans are very helpful. So if you look here on one of the scans, you see there's actually a dehiscence all the way through. This is actually a very early stage 2 macular hole instead. Pseudoholes, hear a lot of talk about that. Pseudoholes are a term that really came before we had OCT. When we have a very fine epiretinal membrane across the top, you get contraction of the epiretinal membrane. Instead of having a nice rounded edge of the fovea, you get a sharp edge. And when you look in with a slit lamp, it looks like there's a hole, but there's not a hole. We're going to talk a little bit more about this and how you determine that that's schisis as opposed to cyst, but that's a little retinal schisis. Now here's an example of something that looks like a stage 1 hole, but it's not. Now if you look right here, there is RPE, but it goes up and over the hole, and it doesn't come across. This is a small retinal pigment epithelial detachment that mimics a stage 1 or an impending macular hole. I think I'm beginning to understand how all these entertainers feel without an audience. This is kind of bizarre. I've been on the receiving end. Oh, I've got my audience back there. Okay. So here's an example of how you have to be a little careful how you interpret OCT. And this is the same patient. I'm getting a wave in the background. So right here, there is a cystic change in the retina. And if you look at this upper scan, that was a scan that came right through here where that blue line is. And this is actually one of these atrophic lamellar holes, and we're cutting right through here. So this is actually not a cyst, but this is an atrophic fovea. So Again, using something like a radial scan can sort that out. Here is a true lamellar hole. We have different sorts of holes that get similar names. In the true form of a lamellar hole, you can see the older images on the bottom. That's the way our system works. And the posterior highlight comes down here, is attached to that bit of retina and comes back over. And over time, this is about a 3-month period of time, this little flap broke away and you have a defect in the fovea and a little bit of foveal tissue floating in front. There's actually tissue across here. Sometimes these are compatible with quite good vision, except the patient will be really annoyed by that little piece of crud floating in front of his vision or her vision. Here's another type of macular hole. This is a myopic macular hole. In your high myopes, you'll see this, a big bend in the back of the eye. So this is the staphyloma. And you can see the macular hole between here and here. You can see the pigment epithelium goes all the way across. And up here, you just see really atrophic retina. There's no layering, there's no detail. That's a sign that this is quite old and it's been there for a long time. This person sat here with this little bit of submacular fluid for years. You might be tempted to fix that. I chose not to because she was stable, she was happy, the other eye was good, and this is kind of dead tissue. This isn't going to see any better. And sometimes you make good decisions and sometimes you don't. 7 years later, she detached from that macular hole. Retinal detachments from macular holes are very rare. We only see those in high myopes with staphylomas, but she indeed got a retinal detachment. A lot of this stuff over here is just sort of artifact, but you can see that the retina is completely separated. You can't see the outer layers. And this is her after surgery. Now, just, something you might see on your OCTs when you see this. See this right over on the right side. You can see a little bit of it on the left. This is something we see in high myopes, and it's just an optical anomaly and an artifact. It's just, we don't see that in most people, but people that have really long eyeballs confuse the system. All right. So with that, we'll move on to cystic macular abnormalities. This is an Arctic gentian, one of my favorite alpine flowers. This was taken up near South Arapahoe Peak. All right. And just so you know, I just noticed that I'm labeled as Justin Canoff. I hope you all know that I'm not. I'm Bill. All right, so this is looking at cystic changes. There's quite a few different cysts that you can find in a retinal area in the macula. And this is diabetic edema, and there's several things here that are important to know. First of all, these little dark areas are the cysts, and they're all kind of round. They can be very vertically round. In this area here, they typically don't have sharp edges. They're typically not irregular. You move through here, there are these little white spots. There are not that many things that give you nice little white spots like this. This is hard exudate, and you can see that in some of the crystalline retinopathies, but this is pretty classic. You don't tend to have edema in crystalline retinopathies. You should be able to look at this and just say, that's a diabetic edema, hard exudate, and throw in another one here. This one's a lot worse. I put this one in here specifically to show why we put a lot of effort into keeping hard exudate out of the fovea. This is all hard exudate. It's in the fovea. This person's vision is relatively poor. And look at the ellipsoid zone. You come across, you come across, you come across, and it's kind of looking a little ratty. And then it's kind of missing. And then you pick up a little bit of it in here, and then there's none right in here. There's none through here. And then you've got some in here. And this right in the critical central foveal area, that's destruction of photoreceptors and fairly poor vision. Moving on to further, or another example of diabetic edema. Sometimes the edema is so bad that fluid leaks underneath of the retina. And again, you know that subretinal fluid because the pigment epithelium comes nicely right across there. Here are the layers of the retina, the ellipsoid zone, the external limiting membrane. They come right up and over. Hard exudate again, and look at all of the cysts. They're all rounded, oval, even, not irregular. All right. This one, every once in a while, we'll slice a microaneurysm. That is a microaneurysm right there. And again, right around it, you can see where it's leaking. You have nice round little circles. All right, so this is an example, and we'll talk a little more about macular ischemia, but this is somebody who's had severe edema, who has had resolution, with VEGF inhibitors. And in this case, the vision's poor. And if you follow the ellipsoid zone, comes into here, it gets kind of ratty. See over here, it looks pretty nice. You just start losing it. There's no ellipsoid zone through here, maybe a little bit there. And then on top of it, look at the rest of the retina. No layers. This is all ischemic retina, inner retinal ischemia, the capillary bed's shot. And this is very typical of macular ischemia. So again, if you're wondering why a patient's not seeing well, this is something you wouldn't see on your clinical exam. But with OCT, you can look in and say, that's the problem. So this is pseudophakic CME. You all see a lot of post-cataract patients. And any post-cataract patient who says, boy, I sure saw great that first day, and on the third day I started seeing worse, you need to get an OCT. The edema in this is in Henle's layer, which is the outer plexiform layer, which if you look right here, it's this little whitish layer on the normal scan, and right there is your outer plexiform layer, and you can see right in here you've got cysts. This is very mild CME. I'm sure you've seen it where it's a giant mound. But again, with the exception of this one that's kind of sharp looking, all these other ones are nice and round, and they'll have a very typical image on fluorescein. Actually, I've just been told that if you raise your hands, we can ask questions. So why don't I take a moment and see if there are any hand raises? You have to digitally raise your hands. What does that mean?
There's a button that says raise hand.
Oh, I guess there's a button that says you can raise your hand. So why don't we stop and see if anybody's got some questions? How's our...
You're doing such a good job of explaining.
No questions. Okay. My Zoom czar says we're good to go. All right. So,
Raise a hand anytime they want.
okay. So, yeah, Dr. Kanoff says that anytime you have a question, raise your hand and we'll stop. And I love interjection because this feels very sterile and odd without questions. So anybody with questions, digitally raise your hand. So here's something we see quite frequently. This is called foveal schisis. This can occur either with or without epiretinal membranes. This person has a mild epiretinal membrane. Excuse me. So with epiretinal membranes, they're often tractional. Without epiretinal membranes, we assume that these are genetic. And the way you can tell this is schisis and not pseudophakic CME, you can see it's in the same layer, Henle's layer right here. But look at this, it's very sharp. You tend to get these triangular spaces where it's splitting. And there's nothing round, nothing even about this. And if you were to do a fluorescein, there's absolutely no leakage as well. So these are always impressive. This is myopic macular schisis. We see this in, oh, I see a raised hand. Oh. So the question is there treatment for foveal schisis? It depends on the cause. Here, let's go back. If it's definitely caused by traction, and you can tell on the OCT, there's an epiretinal membrane that's pulling on it, surgical removal of the epiretinal membrane, a gas tamponade for a few days can sometimes collapse the schisis and help. Some of these that have no epiretinal membrane that are probably genetic, they're a little tougher. You can do a vitrectomy with an internal limiting membrane peeling and gas, and sometimes it works. It can be very disappointing. I tend to be fairly conservative with these, and unless the patient's having a significant decline of vision, probably dropping below 20/30, obvious progression, I typically leave them alone. I've followed people like this for 10, 15 years, and their visions remain in that 20 to 20/30 range, and I haven't intervened. So I only intervene if it's getting fairly significant. All right, myopic macular schisis is fairly impressive. This is thought to be due to the internal limiting membrane. I guess I didn't mention internal limiting membrane. The internal limiting membrane lies on the inside of the ganglion or the nerve fiber layer. And it's thought to be the foot plates and of the Mueller cells. The Mueller cells are the ones that transverse the retina and are really structural cells. So in high myope, sometimes this layer starts to contract in the staphyloma, and as it contracts, the retina no longer wants to fit, and you get this very, very impressive macular schisis. This one actually has a stage 1 macular hole. So, you know, in this setting, we often just leave it alone. This person was 20/30 for years and years and years. Unfortunately, one day she came with a little percolation in the middle. The posterior hyaloid separated and she ended up with a small hole, ultimately had surgery and she did well. These are troublesome though. They're not the easiest things to operate on and they don't always do this well. So when they look like this, we tend to be very conservative. Yes. Ooh, I don't remember, but I think she was in the, what's that? Oh, I'm sorry. The question was, how myopic was she? And I think she was in the 15 range, minus 15. This person was interesting to me because she had this problem in her left eye. She did well with surgery, and then she got a detachment in her other eye. This eye came back to 20/30. She had a Makoff detachment in the other eye and came back to about 20/70. So this ended up being her good eye. So these are atrophic cysts. These you can tell they're atrophic because of their shape. And if you look in here, these two here are kind of round, but look at this. It's erratic, it's irregular. There's nothing smooth about it. These often overlie geographic atrophy, which we're going to talk about in a minute. This is a macular degeneration patient. And very faintly, you can see a little line of vitreous going here, and this is vitreofoveal traction, which we're also going to talk a little bit more about. This is Rainbow Lakes, just north of Nederland. I hope you've noticed there's a fall theme to the photography. The traction, no, this is post-vitrectomy. It's nice and smooth. This is the way we want it to look. Okay, epiretinal membranes. So epiretinal membranes are very common. We see them from a variety of causes. Anything that basically irritates the posterior pole of the retina can cause them inflammation and trauma, posterior vitreous separations, laser, surgery, all sorts of things can do this. They cause their problems because they contract, just like any scar tissue throughout the body. You can see this is a nice, fairly prominent epiretinal membrane, and it has contracted and caused wrinkling of the retinal tissue. I often explain to people that, because we have a concave eye, when you contract an epiretinal membrane, it creates anterior posterior traction and causes thickening. In terms of surgery, we like seeing images like this because this is very loose. These come off very nicely. An eye like this would do quite well removing an epiretinal membrane. This is an epiretinal membrane in diabetes. They tend to get different sorts of epiretinal membranes. They can have regular ones, but they often get these really dense, fibrotic membranes that are associated with proliferative disease. And in this case, this person's vision, there's a little traction on the fovea. This person's vision is about 20/60 because this thing is so thick she can't see through it. This is a woman I've known for 25 years. She's elected not to have surgery. This would be a very simple vitrectomy to remove that, and she'd probably get an improvement of her vision. But she sees well with the other eye, and she's just opted to let this alone for many, many years. That hasn't changed a bit. So vitreofoveal traction is a situation where the vitreous pulls on the fovea. I tend to call this vitreofoveal adhesion because if you look at the posterior vitreous, it's separating here and here, but it's generally attached, and it just sort of stuck to the fovea. It's really not doing anything. Here, though, you start getting traction, and this is where people will start getting symptoms. You can see there's a little plateau right here. It's a little like Green Mountain, I guess. Vitreous comes down here, and then it leaves here. And this is where we start getting symptoms. This person also, we're going to talk about macular degeneration in a second, has a little bit of AMD. Yes?
We got a question from the audience.
Yes?
So they want to know, so if you could repeat the question, they want to know about Jetrea for broad ERMs and vitreomacular adhesions. What's the current state of Jetrea?
Okay. Well, I'll tell you what, let me get to like 2 more slides forward and then you'll have some examples and I'll talk about it. Oh, I'm sorry. I apologize. The question was, could you talk about Jetrea and when you use it, what's the current status and when is it useful and when is it not? So let me answer that in just a second. So here's symptomatic vitreofoveal traction. When it starts getting like this, often people are symptomatic enough that they want to do something about it. You know, it starts pulling and sometimes you actually will get subretinal fluid underneath because you have so much traction. Now, this one is vitreofoveal traction, lamellar hole formation. We kind of looked at that earlier. And now here's the slide I wanted to get to before we talked about Jetrea. This is broad-based, not really vitreofoveal traction, but vitreomacular traction. And then again, you look at this and these are kind of round, but look at the edges, they're sharp. This is foveal schisis due to traction. So along with the previous question, this is a type of schisis that would probably respond quite well to removal of the epiretinal membrane. Now Jetrea. Now Jetrea is sort of an interesting drug. We were very excited about it. It works really well on cases like these. It's a very small attachment and it worked quite well. It is an injectable drug that breaks down the adhesion between the vitreous and the retina. This one, it probably wouldn't work so well. These broad-based adhesions, you know, it generally failed. It was exciting because we thought we were going to keep a lot of people out of the operating room. The problem was it had about a 50% success rate, even with the small adhesions. And there were some very, very bad sight-threatening complications. Some people, it would separate and they would have horrible ERG changes. People would have afferent pupillary defects, visual field defects, and often a significant reduction of central vision. It was bad enough that most of us quit doing it. The complication rates from vitrectomy were very small. We had a 100% success rate. And I don't know anybody who still uses Jetrea. I don't know, Dr. Canoff, do you know anybody that still uses it? No, I haven't used it in years. The risk-benefit ratio just wasn't there.
We have one other question come up.
Yep.
So they want to know what kind of symptoms would a patient typically have with VFT?
So the question was, what type of symptoms would a person with vitreofoveal traction have? So in a patient like this, it's usually mild metamorphopsia. Straight lines would have a bend in them. Sometimes you look at like a telephone pole, you might have a little indentation in the side of the telephone pole right at the fovea. Sort of similar to the old Watsky sign, which we don't really use anymore. Those would be the main, just general central blurring. They're often subtle and sometimes they're more severe. You know, this person here had fairly significant visual loss from the traction. It was just distorted blurry vision. Incidentally, that's that same patient. That's this one here. This is post-vitrectomy and, you know, they did quite well. All right. This was taken west of Jamestown at my childhood home, which was a little ranch not too far east of the Peak to Peak. All right. So this one, we're going to move into macular degeneration. So macular degeneration, OCT is extremely useful for this. I find that sometimes I'll see drusen on the OCT I can't see clinically. Sometimes I see them clinically I can't see on the OCT. And so you put the two together and you can diagnose mild macular degeneration much more accurately. So Priscilla, would you be so kind as to grab me that coffee cup? It's the silver one there. No, I got a cup over here. Anyway, pardon me. If you look through here, we're going to look right along the retinal pigment epithelium, and you can start seeing some little lumpy bumpies in there. Nectar of the gods. Okay. So typical drusen, little bumps. Here's a larger drusen, probably a coalescence of several drusen. And so these are the typical findings we'll see in mild dry macular degeneration. They can get bigger. This is where we start calling them pigment epithelial detachments or soft drusen. They can look fairly impressive. They get bigger and bigger. These, some people are splitters, some are lumpers. You could call that a small retinal pigment epithelial detachment. I tend to call them pigment epithelial detachments in honor of Donald Gass. They're the solid ones that are, not huge. Sometimes those will be soft drusen when you look into the eye. But again, let's go back to the anatomy here. Here's the pigment epithelium, and look, they go up. So you know it's a pigment epithelial detachment. There's no retinal pigment epithelium here. And then the other layers just right up above the bumps. And the other thing about these is they're solid. They have an accumulation of lipofuscin, which is that yellowish material that makes up drusen. This is a serous retinal pigment epithelial detachment. You can see it's very dark in the middle. And again, follow the retinal pigment epithelium. It goes right up over the top and comes through. And you can also look in here, the retinal pigment epithelium and the ellipsoid zone are kind of ratty. So this is a person who doesn't see great. It's not a real healthy looking retina. These are interesting. This is a retinal pigment epithelial rip. So the way this used to look, and I wish I had the pre-picture in here, the RPE comes up, it's all wrinkly in here, and then it stops, and then there's no RPE. You can tell that because of this appearance here, which I'm going to talk about more in a minute. This is missing RPE, but this used to come all the way across to here. And then about 180 degrees of the edge of this sort of blister of pigment epithelium suddenly ripped. And this is very rapid. People will report that in a matter of minutes, they went from seeing really well to being count fingers because there's no pigment epithelium now underneath of the fovea.
Bill, you got a question?
Yes, question?
So the question is, in AMD, do you find the choroid typically appears thicker or thinner? If so, why?
Okay, so the question is, what about the choroidal thickness in macular degeneration? And I am going to get to that in just a little bit, but I will say it right now. If you look at this, this is very thin choroid. So our choroid thins with age, and we also have thinning of choroid with vascular disease, and we have worse macular degeneration with vascular disease. And so we tend to see quite thin choroid as we see our macular degeneration patients. So. And we're going to talk a little bit about choroidal thickness in a couple of minutes.
One more question.
Yes, another question.
So we have another question from the audience. So you mentioned a drusen that you see with slit lamp exam, but not on OCT. What's your anatomic explanation for these drusen you can see on the slit lamp, but not the OCT?
So did they all hear your question? Yeah. Okay. So to answer that, I think they're just so small. They aren't big enough that they're showing up anatomically with our 10 micron resolution. And the other thing is when you use a slit lamp, you can bring the light in from different directions. And if you bring the light in from the side, you get sort of a sclerotic scatter like you would in the cornea, but it occurs down in the retina. And it will often cause an illumination of little tiny drusen that you might not see otherwise. All right, so here's basal laminar drusen where you get just a thick RPE and Bruch's membrane complex. This person's also got a little epiretinal membrane. Moving on, we have this disorder with a very long name, adult onset foveomacular dystrophy. A very similar lesion occurs in macular degeneration. You can see there's some drusen and irregularity through here. And then you have this deposit that's a fairly large deposit, and this looks a whole lot like the adult Best's lesion. And if we move on to the next one, here is AOFMD, kind of a typical lesion, and they're very similar. They tend to be very round and even in true AOFMD, but these pseudovitelliform lesions, they'll tend to be more irregular. The edges are less distinct, and they'll be associated with drusen. That's just kind of, well, nothing more to say about that, I guess. All right. Geographic atrophy. So I find OCT very helpful here. You can often pick up geographic atrophy or even sort of pre-geographic atrophy. So again, we're going to follow, well, there's a few things in here. First of all, right here, there's two things that are causing a shadow. And keep in mind, this is all generated by a laser coming down, reflecting off of everything and bouncing back. So here, these two vessels are blocking the laser light and you get this shadowing coming down below. Now you move over here, you have the opposite, retinal pigment epithelium, and you can see it just kind of peters out right here, picks up again here. There's a little pigment epithelial detachment. And right here, you see streaks of light coming down into the choroid. And that's because the laser can penetrate significantly deeper than it can where there's intact pigment epithelium. Now over here, you see all this streak. This is an area where the RPE is beginning to degenerate. So this is a useful tool. And this person clearly doesn't see well because there's no pigment epithelium, there's no ellipsoid zone, there's no external limbing membrane, and even some tiny little micro atrophic cysts are starting to develop. This is just an anomaly that's kind of fun. It really has no meaning. It's called outer wall tubulation. We see this in really chronic macular degeneration. It is a collection of cone cells. If you looked at this en face, it looks kind of like a little worm as opposed to this little tube when you cut it in half. It really has no implications other than, you know, the degenerative changes are old. Moving on to wet macular degeneration. That's my backyard. I like this image because it's a nice example of the difference between subretinal fluid from wet AMD and from a retinal pigment epithelial detachment. So follow the retinal pigment epithelium you come across, it rises up, comes back down and keeps going across. And then right here, you follow the ellipsoid zone, it just comes up and above. And this is, therefore, subretinal fluid. So wet macular degeneration, as you know, it's coming from the choroid, growing up into the RPE, sub-RPE space, Bruch's membrane, subretinal space. So you can get leakage into multiple areas, including cystoid edema. And again, back to the choroid question, look how thin this choroid is. This is extraordinarily thin choroid. Here's a large serous pigment epithelial detachment. Now that RPE rip, it would have ripped right there, and that RPE would have just retracted. Here's a little subretinal fluid again. You can see the difference between that RPE coming across. You can see the other layers of the retina coming up above the subretinal fluid. This is an atrophic lamellar hole along with cystoid macular edema, lots of drusen, geographic atrophy, a little bit of everything we've been talking about. Some very chronic wet AMD patients develop these very large cysts. I've got patients where the cysts are so big it doesn't even show up on the OCT because it extends beyond, beyond the anterior portion of the image. Here's some subretinal fluid, and this is just a chronic poor-seeing eye. This is something we generally probably wouldn't even bother to treat. This one is a classic disciform scar on OCT. You can see a big fibrotic mass under the retina. The overlying retina is all degenerated. You can see there's no layering. You got a little fibrosis here. This is probably more for Dr. Wolford, our football fan over there. This is, Hookham Horns maculopathy. I've always liked that one. So, all right. So many of you know I inherited a place up in Maine, and I was sea kayaking one day, and I couldn't help but take a picture of this lobster boat. Obviously, it was a guy who lobstered maybe as a hobby on the side, maybe as an optician on the side. We'll see. All right, branch retinal vein occlusions. So this is before and after Avastin. This is one of the reasons I like the grid. I like these vertical slices in a branch vein occlusion. You can see perfectly normal retina on the right, which is inferior, and in massive swelling here, subfoveal fluid, and this is very typical of a vein occlusion. And you have cysts all throughout the retina. Pretty much every layer is involved in this cyst. And this gives you an example of how well Avastin works or any of the VEGF inhibitors work in these patients. This is a patient post-Avastin, and this is again a vertical slice, very normal looking retina down here. You can see all of our layers nicely. But look what happens in a lot of these patients. This is sort of the result of not only CME, but ischemia, like we showed you in that diabetic. Look at the layering over here compared to over here. It's all messed up. And this is also a good example of how vein occlusions are an inner retinal problem because the inner retina is damaged, but look at all the layers of the outer retina. The choroid's still feeding the photoreceptors, so the outer retina is still healthy, but the inner retina is all messed up. Now, this is an area where I have found OCTP to be extraordinarily helpful. I have had so many consults over the years for unexplained visual loss, and you look at a perfectly normal retina. It's got to be a retinal issue. It's not a neurologic issue, and you just kind of guess. Maybe they had an artery occlusion in the past, and now you don't have to guess. OCT tells you. So this is a cilioretinal artery, and you can see right here, marked disruption of the inner retina. It's all whitened. This would be that white patch you would see clinically. This is actually dark mostly because this is shadowing. You're not, see the shadowing down here? You're not getting any detail. And now here, just 3 months later, you can see that same area. It's thin. The inner layers look white and are opacified. And this is just pretty much pathognomonic for a retinal artery occlusion. And again, if you look right down here, the outer retina is fine because it's an inner retina phenomenon. This is a central retinal artery occlusion that had a pretty normal looking retina, but terrible vision. And look at the whole inner retina. So the outer retina, again, very healthy. You see all your layers, your ellipsoid zone, your RPE, and then you come and the inner retina is all extremely thin and it's just white and opacified on this. And this is well past the cherry red spot. This is chronic many, many months after the event. I love saying this name, acute multifocal placoid pigment epitheliopathy. So this is another ischemic disease, and it was very controversial for many, many years what caused this, but see these white plaques in here. Those are typical AMPI pictures. ICG angiography, you can see there's defects in perfusion of the choroid capillaris here. But if you look here, this, you know, again, going back to our anatomy, if you look in here, you've got normal choroid, you got normal choroid capillaris, and look at right in here, it's disrupted. So this is an area of ischemia. Look at the overlying RPE and ellipsoid zone. It's all ratty and irregular. And again, the inner layers are fine, but this is an outer retinal ischemic event. So you've got this basically choroidal ischemia causing this little zone of damage, which correlates with the whitening you saw in the color photograph. This is the Monarch Crest Trail. And the one person in there that you guys should know, that's Dr. Tilton. So, you know, back to choroidal thickness, which was asked a little bit earlier. There's this newer concept of the pachychoroidopathies, which came up a few years ago and really sort of came to be when people started recognizing that in certain things, especially central serous choroidopathy, people had very, very thick choroids. So this is a normal choroid, pretty much, maybe a slightly thick choroid, but fairly normal in a young person. You can see it's markedly thickened compared to what we were seeing in those AMD patients. And now look at this. This is a really thick choroid. It's almost going outside of, here's the posterior edge. It's almost leaving the scan. So that is a thick choroid. And again, here's central serous, thick choroid. And this is a big clue. If you see, you know, you can tell this is subretinal fluid again. Retinal pigment epithelium comes all the way across. You can see ellipsoid zone. You can see the external limiting membrane coming up and over. You know, if you see thin choroid and you see this, you got to start thinking choroidal neovascular membrane. You don't sit on those patients. You know, those people need a fluorescein right away. Make sure it's not a choroidal neovascular membrane, because if you don't treat that, they lose vision. You know, obviously central serous, you got time. Something else that I think is really interesting on these scans, we'll get a sip here, is this layer right here. Do you see how fuzzy and thick that is? That's a sign of chronicity. If you guys all recall your retinal physiology, the outer segments and the plates that develop in the outer rods and cones are constantly evolving and being phagocytized by the retinal pigment epithelium, where the chemicals are all reprocessed and kind of spit back to the photoreceptors. Here, there's no phagocytosis. So this is all outer segment, you know, schmutz and debris building up and thickening on the outer part of the retina. And that's just a sign that this has been here for a while. So here is an example of subretinal fluid, that same sort of stuff collecting on the outer part of the retina. This is wet AMD. And again, look at a very thin choroid. 5 minutes. Okay, we're going to go fast here. These are pockets of subretinal fluid after detachment. That's just kind of a weird phenomenon. I won't go into much, but it is a cause of delayed visual recovery. Here is central serous resolved. You can see fairly thick choroid. MAC-off retinal detachment. Again, you follow your anatomy. There we go, RPE, retina. This is a chronic RD. You can tell it's chronic because the fovea is very thin and there's cystic changes. So this has been there for a while. And here is something that's, I think, is interesting. Here's ellipsoid zone that's all irregular and ratty. And after several months, you can see it's reestablished and the patient's regained a fair amount of vision. Here's a patient that didn't regain as much vision. And you can look, there's missing ellipsoid zone in the fovea. So you have an explanation for that 20/80 vision. Just real quick here, this is bullous schisis with an outer wall hole. And this shows the anatomy very nicely. There's the inner wall of the split of the bullous schisis. There's the break in the outer retina with this little rolled edge, which you see clinically as that white edge.
Bill, we have another question. So would polypoidal choroidal vasculopathy be considered one of the pachychoroidal choroidopathies?
No, I would not put that in the category. All right, so just real quick, laser scars, full thickness. This is panretinal photocoagulation. This is a subhyaloidal hemorrhage. Again, back to the anatomy, that's vitreous. There's the inner retina, so you can tell that hemorrhage, that bright area there is between the retina and the choroid. This is another subhyaloidal hemorrhage. If you turn this on its side, so this is on the top, this is a melanoma, but you see this line right here? This is gravity. This is why we see boat hemorrhages. You see them mostly in diabetics, but that's a classic boat hemorrhage that you would see. Stargard's, just suffice to say, everything's thin. There's no ellipsoid zone. I'm being told I have very little time. We'll skip MUDES. This one you guys all see. This is commotio, post-trauma. We've had theories for years about why the retina looks white, and now we know. Look at that inner retina in a commotio patient. All irregular, and all that those little folds create that white sheen you see, and here's after recovery, and that's all gone away. I call this evanescent foveal syndrome. This basically, there's a fovea one time, and then 3 months later, there's no fovea, and that's because my tech missed. So be careful about aiming your camera. This was way off. That's nasal retina. My tech mistook the nasal side of the eye for the macula. This one also doesn't have a fovea, but this one is kind of a fun one. And being quick, I'll just tell you what it is. This is a person with ocular albinism. People with ocular albinism often have foveal hypoplasia and do not have foveas. That's why they have that wandering nystagmus. 2 seconds on OCTA. It's an interesting technology that uses multiple images and looks at the difference between images. And if there's a difference, they assume it's blood flow and they generate these nice images. This is actually a polypoidal patient here. That's what it looks like on OCTA. Here is a choroidal neovascular membrane here. Here's a very classic choroidal neovascular membrane. These are, we've been underwhelmed. Occasionally they're very helpful, but there's lots of motion artifact, media opacity. There's a million reasons why it's not the greatest technology, but it's cool when it works. So basically, this was last ski season, and hopefully we'll have another good ski season. That's actually the only photograph that's not from here. That's me in British Columbia last January. So any questions? Keeper of the questions.
No question. You want to mute yourself?
All right. If I can find my mute.
So just one quick update about patient referrals and communication. We try to do the best we can communicating with you about patients. There's a couple different ways, and there's one new way to get in touch with us that I wanted to highlight just real quick. So one option is, the ways that you guys have been doing it for years, able to call us directly with urgent referrals at our main number and hit option 2, which will get you right to the doctor's line. Nights and weekends, we can all be reached on our cell phones. And if you guys need more referral packets, please ask Priscilla, and those have our cell phones all attached to it. Non-urgent referrals can always be faxed the way we have been doing. And there's an area on our website that's entitled For Physicians, and there's a bunch of forms. But the new way, which might be easier for you and your staff, is doing direct online referrals. It's completely secure and it's HIPAA compliant. And it's accessed from our main website, and you click on For Physicians, and then there's this link here that's called Patient Referral Form Online. And it allows you to type all the information directly into the computer and then just send it in electronically, which hopefully will make it a lot easier. And one of the great things about that is you're able to upload clinical images directly into the referral. So that way, if you want to send OCTs or Optos photos, we'll be able to see them instead of the poor quality that they come through on the fax machine. We'll be able to get the high resolution images. So again, main website, click on the For Physicians, and then the patient referral online, and hopefully that'll make things easier for you. Okay, so our next presentation is going to be from Dr. Parikh, and it's Neuro-Ophthalmic Emergencies, a review.
Okay, so good morning. I am going to be talking about some neuro-ophthalmology conditions.
Sorry, we shared the wrong screen because it's coming.
Okay, sorry about that. Restart. So I'm going to be talking about some neuro-ophthalmology conditions. I think most of you know that I am a glaucoma specialist, so not my specialty, but these are the things that rarely walk into our offices, but all the things that we're all worried about missing. And it's always good to review these no matter what. So it's an appropriate post-Halloween talk. And I have no disclosures. And the goal here is just to go over just a handful of conditions that have a high ocular morbidity and also potential mortality. And what I want to talk about is overviews of the anatomy, the neuroanatomy that goes into the, underlies the pathophysiology of these conditions, the diagnosis and the management of these conditions. So these are the things that are scary when they walk into your office. Patients complaining of double vision, change in pupil size, really bad headaches, acute vision loss. And the things that you should always be concerned about is if you have 2 or more of these following signs on exam. So if you have a pupil abnormality plus an eyelid abnormality plus motility abnormality, any combination of those should be concerning. So we're going to talk about some of these symptoms and what can potentially be causing them. So the first one is my least favorite. Whenever I see diplopia on my schedule, my heart rate goes up. So we're going to talk a little bit about diplopia and the approach to diplopia. So any patient who comes in with diplopia, a couple things you want to know about. You want to ask, of course, if it's monocular or binocular. I think all of us know what that means, but if it's binocular and a patient covers either eye, the double vision should go away. That's the situation in which you're going to be concerned about a muscle imbalance. If they have monocular diplopia, you're going down a completely different pathway that may be less concerning. You want to know if the diplopia is horizontal, vertical, or oblique. That can help you kind of just in your head try to start thinking about what this might be. You want to know if the diplopia is comitant or incomitant. So Typically incomitant is going to be what we're more worried about with a potential nerve issue. You want to know if the diplopia is intermittent or constant. And then you want to know if this patient has a history of strabismus and has ever had any type of strabismus procedure in the past. So I'm going to show a picture here, and I'm just going to give you guys a couple of minutes to look at it. And then we are going to try something. I've put in some poll questions. It's totally anonymous. It would be great if you guys can participate. And I'm just going to ask a couple of questions throughout the presentation.
Are you ready for the first poll question here?
Yep, I'm gonna, yep, go ahead. So Justin is gonna put this poll up. So the first poll question is, what is the next step in the management of this patient?
Okay, so the poll should be live. There we go. Okay, great. So we're getting people voting. Awesome.
Great. I'll give you about 20 seconds and then we'll put the results up of the poll.
All right, we'll just give it about 5 more seconds. All right, we're going to end the poll and let's see.
Let's see what
And
we
then
got.
we'll see if we can share the results.
Okay, so we have most people saying MRI of the brain, a couple of people for observation, and about a third of you voted for CTA. So let's just talk about this real quick. So you may have looked at this and thought this is a third nerve palsy. So that may not have been really hard to figure out. So if you're looking at this patient, this is a complete third nerve palsy. The middle screen here, you can see a complete ptosis on the left eye. You can also see in general in most of these gazes, the eye is out and down and out, which a complete ptosis with an eye that's down and out is basically a complete third nerve palsy. The one thing you want to see in these pictures, and you can kind of see it in most of these pictures where this eyelid is lifted, is that the pupil on the left side, the affected eye, is clearly larger than the pupil on the other side. So this is a mid-dilated pupil that you can see in all these gazes. And a third nerve palsy with a dilated pupil is a posterior communicating artery aneurysm until proven otherwise. And this can be a fatal condition, and it is an emergency. So in this particular case, the test of choice is actually a CTA. A lot of neurological conditions, we see MRI brain is going to be a good option. But in this particular condition, you need to rule out an aneurysm. To rule out an aneurysm, you need an angiogram. CTA is the fastest way to get an angiogram. You could potentially also order an MRA. However, a patient like this often is going to go to the emergency room, and the test of choice is CTA in the emergency room. So let's just talk about why we see this. So the third nerve has, just like all the nerves, has quite a complicated pathway. These are the pathways that we learned about a long time ago, and then you kind of forget over time when this is not something you're dealing with on a daily basis. But you have the third nerve nucleus, which is in the dorsal midbrain. It leaves the midbrain anteriorly. It travels in the subarachnoid space near the posterior communicating artery. It then is going to enter the cavernous sinus, go through the superior orbital fissure, and in the superior orbital fissure, it's going to branch into 2 divisions. So it's going to branch into the superior division, which is going to be innervating the levator and the superior rectus muscle. And then you have the inferior division, which innervates the medial rectus, the inferior rectus, the inferior oblique, and also sends parasympathetic fibers to the cervical ganglion, which controls the pupillary sphincter. So if the third nerve is involved, you potentially can have effects in any of these muscles, plus it can affect the pupil. If the pupil is affected, again, these are parasympathetic fibers. They control the pupillary sphincter. If you lose the sphincter tone, the pupil is going to appear dilated if those branches are involved. So just quickly, looking at the muscles. In a third nerve palsy, the 2 muscles that are spared are the lateral rectus muscle, which is controlled by the sixth nerve, and the superior oblique muscle, which is controlled by the fourth nerve. The lateral rectus unopposed is going to make the eye go out. The superior oblique muscle unopposed is going to make the eye look down and intort. So this is the reason you get an eye that is down and out. Whenever you're looking at a third nerve palsy, or you have a concern about a third nerve palsy, you do want to test these two muscles which test those two cranial nerves, cranial nerve 4 and 6. You want to make sure that this is an isolated third nerve palsy. If there are other cranial nerves involved, then this is going to localize to a different area of the brain. So I'm going to show you a video. Hopefully it's going to run. Oh, let's see. Okay. So there was volume on this video, but I don't think it's playing. Is that right? Okay, so I'll talk during it. So this, okay. So this is a left third nerve palsy, but it's a partial third nerve palsy. Initially, you saw that they were holding the brow there to prevent the brow from lifting the eyelid, just to test the levator function there. You can see in this patient, the pupil on that left side is normal. And you can see there that the eye is moving laterally, normally. There's some issue with upgaze. You can see again, lateral movement's normal, and is able to depress some because of the superior oblique function. You can see this eye, the eyelid is not completely ptotic. Then there is some movement in some of the gazes, so it's not a complete third nerve palsy. So the second half here, I just want to point something out. It's just a really good example of this. The patient is now going to follow a target. And you can see here again, to test the sixth nerve, you can have them look laterally. You can see very good movement laterally. But when they look medially and then down, you can see the eye rotate. So that intorsion, it's a really good example of the intorsion. You can see that that proves that the fourth nerve is working properly here. So this is an isolated third nerve palsy. In this particular patient, it was an ischemic third nerve palsy. And this is something that generally improves with observation. So we mentioned in that previous video that, one of the first things I mentioned was that the pupil looks normal. And whenever you have somebody with a third nerve palsy, you want definitely to pay attention to the pupil. And the reason for that is that in the third nerve, the parasympathetic fibers that control the pupil run on the superior and medial part of the nerve. So if you look on the left here, you can see that the third nerve here is along my arrow. And this is the posterior communicating artery running right above the third nerve. And if there is an aneurysm that grows downwards, it's going to be pushing on the superior part of the third nerve, which is why you often get pupillary dilation from an aneurysm causing a third nerve palsy. Oh, I'm sorry. Okay, I apologize. You haven't been seeing my arrows. Okay, so again, sorry, here's the third nerve, and there's the posterior communicating artery running parallel and above the third nerve. And so an aneurysm here is going to compress the third nerve right here. And it's going to affect these pupillary fibers, which is why you can often get this dilated pupil. On the other hand, blood vessels that generally they penetrate the nerve and they're ending sort of internally in the nerve. This is where the fibers are that control the muscles. So an ischemic third nerve palsy may not have pupillary involvement. But it's not a 100% rule. It is possible to get ischemia that causes some pupil involvement. But in general, if you have a normal pupil, there's a little bit more likelihood that this is ischemic. So let's just talk clinically. What do you do if you have a patient like this? The first thing I showed was a complete third nerve palsy, which again is a full ptosis with the eye down and out. If the pupil is not involved in a complete third nerve palsy, it's most likely ischemic. When you're talking about this, if you're talking about the academics of this, in theory, these patients don't need imaging. In practice, these patients generally are going to get imaging. It is possible to have an aneurysm in a different artery that is compressing the nerve from inferior that will not affect the pupillary fiber. So it is possible to get a third nerve palsy with a normal pupil from a basilar aneurysm. And so you're going to image these patients. An incomplete third nerve palsy, always think the worst. The pupil can be normal initially. There used to be some teaching that you might follow these patients closely, check to see if the pupil becomes involved. But generally, again, these patients are going to get imaging. So anything that looks like a complete or incomplete third nerve palsy, rule out an aneurysm. The patient should get an urgent CT-CTA. They can get an MRA if they have renal insufficiency and can't get contrast with the CTA. A CT or MRI brain is not going to identify an aneurysm, so you need that angiogram in this situation. And then you're going to get an ESR CRP on all of these patients as well. And we'll talk a little bit more about that coming forward. Okay, so the next thing we're going to talk about is acute vision loss.
We have a question.
Sure.
So the question is an urgent MRA CTA indicated even in the presence of known diabetes?
So yes, I think the general consensus amongst neuro-ophthalmologists is even if you have vasculopathic risk factors, which you should always ask for, these patients should get urgent imaging to make sure that they also don't have an aneurysm. Of course, an aneurysm can potentially be fatal. Aneurysms that cause third nerve palsies are generally larger than 4 millimeters. So these are potentially large aneurysms with mortality. So they should have imaging. Any other questions? Third nerve?
Yeah, so there is one other question. So thanks for the questions. It makes these talks much more interactive and fun. So and second question is, any pearls for following these patients through resolution? Should we be monitoring the magnitude of prism deviation, ptosis resolution, or any important things to monitor?
So great question. And I don't know if there's an exact rule to saying how often you should follow these patients. If these patients have had normal neuroimaging, and so you've ruled out an aneurysm, and then you've also ruled out any other potential neurologic issue, and the assumption is that this is ischemic, most of these patients are going to resolve within 6 months. A lot of them are going to have a significant amount of resolution in the first 3 months. So yes, during that time, you would want to monitor them. You can certainly follow the deviation to see how it's improving, to see how the diplopia is improving. In conditions where they don't resolve at a certain point and all the appropriate neuroimaging has already been done, there are options for potential strabismus procedures to help these patients with their diplopia. But yes, you would want to monitor them. And again, I would typically see a patient back in 4 to 6 weeks if they had normal neuroimaging, and then see them at about the 3-month point. And again, most people have quite a bit of resolution at that point, then you might see them at the 6-month point after that. Good? Okay, so we're gonna move on. So the second thing we're gonna talk about is acute vision loss. So the things you wanna know in this particular situation is the vision loss sudden or is it gradual? So if you're thinking about sudden vision loss, you're going to be thinking more along the lines of some ischemic event. Gradual vision loss can be potentially inflammatory. It can also be compressive. So you're going to be thinking differently about your differential diagnosis. You want to know if the vision loss is associated with pain, and you want to know if the vision loss is in a specific area of the visual field, or if it's central. So the key to acute vision loss is a good pupil exam, because this is going to send you down a different pathway if you have an abnormal pupil exam. So always you want your staff, if you're in a practice where it's normal to dilate new patients, to know that you should really confirm the pupil exam before a patient with acute vision loss is dilated. And the big thing you're looking for is an afferent pupillary defect. So this is just a quick overview of the afferent pupillary pathway and the efferent pathway here. So you have a light, if you shine it in the pupil, you're going to get a signal that is sent through the optic nerve. It's going to go through the chiasm here, both directions, back to the pretectal nucleus. And then this is where the efferent loop starts. So up to the third nerve nucleus. And then you can see all of this crosses. So the efferent is a consensual response bilaterally, and you're going to have that go anteriorly to the ciliary ganglion, and then this from the ciliary ganglion forward to the pupil. So if you have an afferent pupillary defect, so an issue with the input of the eye sensing light, you're going to be thinking about an optic neuropathy anterior to the chiasm because it's only affecting one eye. In a younger patient, if this is associated with pain, you're going to be thinking about optic neuritis, but an older patient, you're going to be thinking of an ischemic optic neuropathy. Some of the other things, although they wouldn't be as acute, would be, again, like I mentioned, compressive lesions like meningioma or a tumor. So we're going to talk about the most common, which is an ischemic optic neuropathy. And ischemic optic neuropathies, vast majority of ischemic optic neuropathies are anterior ischemic optic neuropathies. Anterior ischemic optic neuropathies are going to have disc edema on the clinical exam. And vast majority of anterior optic neuropathies are going to be non-arteritic. But 5 to 10% are arteritic. And even though that's the minority of them, that's the one thing you always want to think about when a patient comes in with an anterior ischemic optic neuropathy. So giant cell arteritis is the thing that we're scared of in this situation. Arteritic anterior ischemic optic neuropathies generally affect older patients. So the patients are typically over 50. The average age is 70. And the issue with giant cell arteritis is inflammation in the large and medium-sized vessels, and inflammation in the ophthalmic artery and short posterior ciliary arteries is what can lead to an ischemic anterior optic neuropathy. So again, vast majority of these patients, they're going to be vasculopaths. So you do want to ask about the vasculopathic risk factors, but you should always ask these GCA screening questions. So you want to know about headaches, temporal headaches specifically. You want to ask about jaw claudication, which is a very good sign. Jaw claudication basically is kind of a cramping discomfort in the jaw while they're chewing, and scalp tenderness. So definitely want to ask about these three symptoms. Other things, this is giant cell arteritis is a systemic kind of generalized vasculitis. These patients can also have weight loss. They can have malaise. They can have some pain in their joints from muscle weakness. So those are just general systemic symptoms. But a quarter of patients may not complain of any of these things. The few things that you want that may serve as flags when you're seeing a patient and with an anterior ischemic optic neuropathy. Patients who have an arteritic version of this typically have much more severe vision loss. They are often worse than 2200. They may be count fingers or worse than that. They tend to have more of a pale swelling of the optic nerve. So here in this photo, on this left side, this is an example of a ischemic optic neuropathy that's non-arteritic. The nerve is more hyperemic, and you see these flame-shaped hemorrhages. On the left, you see that you have a little bit more paleness to the nerve. You can have cotton wool spots around the nerve and in the retina, which basically goes along with the ischemia to the eye. You can see some abnormal choroidal perfusion on FA. One of the things to think about is a non-arteritic anterior ischemic optic neuropathy. Typically, the discs that we talk about are these discs at risk. So discs at risk means that the patient has a small cup or not much of a cup at all. So when you look in the fellow eye of a patient, if you happen to see a nerve that has a normal size or a large cup in the fellow eye, the unaffected eye, that should also make you think more about an arteritic, potential arteritic condition in the affected eye. And then tender temporal artery. So all patients over 50 should get blood work. So we're gonna take our second poll.
All right, so we're gonna do the second poll.
Okay, so the second poll question is, what serological test is most sensitive for giant cell arteritis?
All right, we'll give it about 10 more seconds for voting. We're getting great response.
Thank you guys all for participating in the polls.
All right, we'll go ahead and end the poll and let's share the results. Everybody should be able to see the results now.
Perfect. So we have most people saying ESR, and then we have CRP followed by platelet count. So when I said all patients over 50 should get blood work, these are the 3 tests that generally you're going to be ordering. So an ESR, a CRP, and a CBC. Between these tests, actually the CRP is the most sensitive test you can order. You're generally going to be looking at ESR and CRP in conjunction. It is possible to have an elevated ESR from lots of conditions as well as CRP, but you can have a normal ESR in the setting of GCA in about 10% of patients. You are very rarely going to get a normal CRP in the setting of GCA. So again, you do want to order all 3 of these tests. The CBC is because you can get a thrombocytosis, so you can get an elevated platelet count in that situation as well. So what is the treatment in this condition? The treatment is high dose oral steroids. But if a person comes in with vision loss and an ischemic optic neuropathy, you are typically going to send them for IV steroids for a few days in the beginning and then switch to high dose oral steroids. If you happen to have a patient present in the office who's coming in with a headache and not so much vision loss, you may just start with an oral steroid. The gold standard is to have a temporal artery biopsy, but this is a clinical diagnosis. There are many times the biopsy will be negative because of skip lesions. The patient will obviously be sent for the biopsy, but you want to look at the whole picture. And the reason we want to start the steroids right away is because there's a 50% chance of the other eye being involved within a week. So
we have a question
Yes.
from the audience. So the
Okay.
question is there a gender bias on giant cell arteritis, or is it sort of equal between men and women?
So it's more prevalent in women. Great question. And it's also more prevalent in Caucasians. So older Caucasian women would be the highest risk group. So these patients are going to
So
be.
what about the worry that starting steroids is gonna ruin your biopsy results, and that might be a reason to wait on doing a biopsy?
So the bigger concern here is definitely potential involvement of the other eye. So you absolutely want to start the steroids. And if we're going to look at the big picture, which is outside of the eyes, these patients do get issues in any large and medium-sized vessels. So they can get problems in the aorta, they can have strokes, which can be fatal. So absolutely, your priority is to start treatment on these patients. You never, ever wait for the biopsy. It's great to try to schedule the biopsy within 1 to 2 weeks. But again, you're going to start the steroids regardless, and then try to get the biopsy as soon as you can. Certainly, I've had patients that were diagnosed with this who had a negative biopsy, but clinically, clearly, had all the symptoms, the blood work and everything to support GCA, and they were treated as GCA regardless of the biopsy results. So you'll always start the steroids first. And you're definitely going to want to recruit help. We recruit help in these situations from the internist or more often a rheumatologist to help manage the steroids. As the steroids in these patients are tapered, the blood work needs to be monitored. If there's any recurrence of elevation in the CRP, they may have to increase the steroids again. So it's not a real simple management. Also, if the person's diabetic or in general blood sugars need to be managed, potential ulcer-related issues, reflux-related issues need to be managed. So you really want to recruit the help of our medicine colleagues in managing these patients. Do you have any other questions about GCA? Can come back to it if you guys think of something. So we're going to move on to anisocoria. So anisocoria is another one of these complaints that you kind of may stress about and maybe forget exactly what you're supposed to do in testing for what condition this might be. The first basic thing you want to figure out when you see a patient with anisocoria is which pupil is abnormal. And the way to figure that out is you're going to be testing the pupils in light and in dark. Anisocoria, which is greater in light, means that the larger pupil is not constricting properly. And for that reason, the larger pupil is the abnormal pupil.
So there was one late question from the for giant cell arteritis. So the question is, could you not do the biopsy right away on a patient on presentation? And we do try to do the biopsy as soon as possible, but even if the biopsy was scheduled for the next morning, you would still want to start the steroids ASAP. So even as quick as you can get the biopsy done, you always want to start the steroids right away and not even wait, even potentially giving them steroids in the morning, even if you're able to do the biopsy, even in the afternoon. So great questions.
Okay, great. I like having Dr. Canoff here to answer questions for me. Okay, so.
She's doing a great job. I think we're going to pass the torch of neuro-ophthalmology.
Oh, please don't. All right. So anisocoria greater in the dark means that the abnormal pupil is not dilating properly. You would normally expect the pupils to dilate in the dark, which means the smaller pupil is the abnormal pupil. If you have anisocoria that's equal in light and dark, it's likely physiologic. So I just put this up to say, it's complicated, anisocoria. And the one thing, I'm not going to go through everything here because we're going to look at some other slides with some examples, but in both situations, you obviously want to look at the slit lamp exam because any abnormalities of the iris, which can be completely unrelated to the sympathetic or parasympathetic neurologic issues that we're going to talk about later can cause these issues. So if you have some sort of iris trauma, if the patient's had a cataract surgery with a floppy iris and has iris trauma, if they have synechia, if they have had uveitis, all these things can cause abnormal pupils. And so obviously we're going to be looking at the slit lamp exam to make sure it's not one of those things. So let's look at, let's look at when the larger pupil is abnormal. So we already talked about the third nerve, and we talked about how the third nerve carries the efferent parasympathetic fibers. These are the fibers that are going to synapse in the ciliary ganglion, and then those fibers are going to go here to the pupillary sphincter. And so any issue along the third nerve can potentially cause issues with an enlarged pupil. Now, of course, the first thing is a third nerve palsy, which we talked about, but a third nerve palsy is really always going to be accompanied by some motility or eyelid abnormality. You're not going to be in a situation where you have a isolated, dilated pupil with absolutely no other abnormality. So if you do have a patient who's coming in and the only thing that the issue is an enlarged pupil, you're going to be thinking about something else along the pathway. The most common is going to be an issue here in the ciliary ganglion with these And then the postsynaptic fibers here going to the sphincter. And the most common thing that we're going to see is a tonic pupil, so an 80s tonic pupil. An 80s tonic pupil, you're going to be looking for a couple of things on the exam, which will help you determine if that's what's going on. You will often see some segmental contraction of the pupil. So you'll have areas that don't react, but then you'll have some areas that do react, and the areas that do react can have some hippus involved with them. So you can get these vermiform movements of the pupillary border. When you have denervation here, you have some upregulation at the postsynaptic terminal of receptors. And so you can get super sensitivity to parasympathomimetic drugs. So in an 80s tonic pupil, if you were to instill a dilute pilocarpine, so 1/10% pilocarpine, because of this super sensitivity, you're going to get dilation. You're going to get constriction of the pupil, and the normal pupil basically shouldn't have any effect. So the other causes, again, like we talked about, are trauma and surgery that can cause this. So I'm going to show a picture of an 80s tonic pupil. And here on the left, you can see that this is a light shining here, that in light, this left pupil is not constricting. Now, in this situation, the issue is in the efferent pathway, not the afferent pathway. So the light is being shown into the left eye, and you see that the right pupil will constrict because the afferent pathway is intact, and there should be a consensual efferent response. So the unaffected eye has constricted, but the left eye hasn't constricted. In an 80s tonic pupil, you can see some constriction of the pupil with an accommodative effort. So here, this patient now is looking at a near target to accommodate, and you see some constriction of the pupil in that situation. And then when the patient looks up to look at distance, you're going to see a lag in dilation of that pupil here. And that's where the term tonic pupil comes from, is a slow redilation of the pupil. So that's an enlarged pupil, but we're going to talk a little bit more about when the smaller pupil is the abnormal pupil. So if the smaller pupil is the abnormal pupil, this is a pupil that basically is not dilating properly. And the issue is going to be in the sympathetic pathway. The sympathetic chain is pretty long, and it starts here in the hypothalamus. You have first order neurons traveling down the spinal cord to the level of C8T2. They're going to synapse here, and you have second order neurons that then pass very close to the apex of the lung and then travel back superiorly to the superior cervical ganglion, which is close to the bifurcation of the common carotid. Or you could also think it's close to the angle of the jaw. And then you have third order neurons that travel with the internal carotid artery. And this is where they start doing a lot of different things that are hard to remember, but they travel with the internal carotid artery. Then for a very short period, they travel with the sixth nerve in the cavernous sinus. And then it's going to travel with cranial nerve 5 with V1. And you're going to have fibers going to the pupillary dilator, and then also fibers that innervate the Mueller's muscle. And you're going to have muscles not only on the superior lid, but also some on the inferior lid. So when the smaller pupil is the abnormal pupil, one of the things that we worry about is a Horner syndrome. And in a Horner syndrome, what you're going to see is a smaller pupil on the affected side, and you can have a variable amount of ptosis. So here you can see the ptosis of the upper lid, and then they can also get a inverse ptosis or an upside down ptosis, which means the lower lid can also rise slightly higher, again, because the innervation is to both lids here. So in any patient who presents with something that looks like a Horner syndrome, you want to find out if they've had any previous head or neck trauma or surgery, which potentially could have affected that sympathetic chain and caused this change. So I'm going to show a quick video here of a Horner syndrome. And you can see that that's that eye, which has a smaller pupil, reacts normally to light, so it will constrict to light, as will the other eye. But then there's some lag in the redilation here. So initially you see that the meiosis looks a little bit more prominent, and over time that pupil does enlarge, but obviously is still smaller than the other eye. So in a Horner syndrome, the test that you can do is an aproclonidine test. An aproclonidine test with a Horner syndrome, the abnormal pupil should dilate. So a normal pupil won't really dilate very much, and you can get a reversal of the anisocoria with an aproclonidine test. So essentially you would put a drop in each eye and you'd wait about 45 minutes to an hour and then recheck the pupils. An aproclonidine test doesn't localize where the problem is in the sympathetic chain. And if you're going to get really involved in this, there are ways to localize, but practically these drops that are used in these situations aren't really readily available. Most people don't have them in their offices. And so most of the time, you're going to do an aproclonidine test and then you're going to proceed with workup. So we're going to do our third poll question. Okay, so our third poll
All right,
question.
poll should be live.
Okay. What condition must be included in a patient with Horner syndrome and facial pain? What condition must be, oh, I'm sorry. Well, what condition must be ruled out? I guess my question, sorry, I wrote this poorly, is what condition are you most concerned about in this situation? So a stroke, a Pancoast tumor, which is basically a tumor at the apex of the lung, or a carotid dissection.
All right, let's give it a few more seconds. A few more votes are coming in.
Thanks for the wave.
All right, so let's go ahead and see the results.
So great. Looks like we have kind of a split between Pancoast tumor and carotid dissection. Stroke was less. Yes. Right. So
the message from the side, the suggestion was that with the facial pain would push you more towards a carotid dissection and less towards the apical lung tumor, although both can certainly cause a Horner syndrome.
Correct. So can we close the poll? Perfect. So absolutely any patient who comes in with a Horner syndrome and headache, pain around the eye, facial pain, you have to rule out a carotid dissection. That is the biggest concern in that situation. Certainly, if you have a Pancoast tumor, you can have pain lower down and less so in the face. So that's the biggest thing you're concerned about here. Practically, like I said, if you have somebody with a new Horner syndrome, you're going to image them. They're going to get an MRI of the entire sympathetic chain, which is going to be brain, neck, and chest to look for everything. And you can have issues at any level of the sympathetic chain and get a Horner syndrome. So you need that brain MRI to look for a stroke, for essential Horners. You need that chest MRI to look for a potential lung tumor that could be causing issues. Thyroid cancers can do this. Metastatic cancers along this area can do this. So again, that's where the neck MRI will be helpful. And you want to look for a carotid dissection or a carotid aneurysm. So you're going to be looking, I should have written there MRI, MRA to look at the blood vessels. Those are the most important things you want to look for. Do we have any questions about Horner syndrome? Okay, so last thing we're going to talk about are visual field defects. So I look at a lot of visual fields and, I'm looking at mostly glaucoma fields, but of course there are those certain fields that just don't look right for glaucoma and you're trying to figure out whether you need to be worried that it could be something else. And you're trying to figure out whether something needs imaging. So I'm going to show a visual field here, and we're going to take our last poll question. Okay, so if you had to localize, where would you localize the lesion causing this visual field defect? Would you expect it to be in the optic nerve? Would you expect it to be near the chiasm, in the optic tract, or in the occipital lobe?
All right, we'll give it just a few more seconds. Some little bit more polling's coming in. Okay, let's put the results up.
Okay, so optic nerve, we have optic nerve, chiasm, I guess a pretty even split except for occipital lobe. So that's great. Occipital lobe is typically where you're going to get a very congruous defect, and it's going to be a homonymous hemianopia, which clearly this is not. So this is an example of a dreaded junctional scotoma. And I'm going to talk a little bit more about that, but this is going to be a lesion that is at the chiasm. And it's going to be maybe just a little bit in the anterior portion of the chiasm, and we'll talk about why. But this is somebody who, when you are going to direct imaging, you're going to want to have the radiologist be looking at the pituitary, at the chiasm, at the sella region.
We have a late breaking question here.
Okay.
Practically
question.
speaking, do new Horner's patients have more systemic complaints or are they usually limited to just ocular complaints?
If it's potentially associated with a carotid dissection or some of these other things, they may have systemic complaints. I don't know the percentages of that. I suspect that a lot of these patients are not going to primarily be seeing us in primary eye care. Of course, the ones we see are going to be the ones that have less systemic complaints. Anybody have any thoughts about that in the room?
I've seen one in the office that had a carotid dissection.
So Dr. Benedict is saying he's had one patient with a carotid dissection present to him in the office. Anybody else? Yeah. And were they complaining of anything else besides the eye issue?
No, it wasn't.
So both Dr. Benedict and Dr. Myers are saying they've had one patient each, neither one of which was complaining of anything systemically, just the eye issue. So I can't answer that exactly. I don't know any percentages there. Okay, so we're going to come back to our visual field here. So neurologic field defects, we all know that when you're looking at a lesion that affects the optic nerve anterior to the chiasm, you're going to get a unilateral visual field defect. But the chiasm, you can really have some variability in how a lesion in the chiasm presents. So if you have a lesion that's affecting the chiasm more so on one side, then you can get a defect like the one I showed, where you're going to have a temporal field defect on one side, and you're going to typically have a temporal field defect on the other eye, just in the superior quadrant. And it can be minimal depending on where near the chiasm this lesion is presenting. And so this is number 2 up here, the junctional scotoma. You can have variable effect here on the eye that has more compression. And then as you go farther back, you have different types of field defects. They're typically homonymous and not bitemporal. And if you're, depending on where you are in the optic radiations, it may be a quadrant that's superior, it could be a quadrant that's inferior. And then as you get posteriorly to the occipital lobe, you're going to have this very homonymous, very congruous visual field defect. So chiasmal lesions are the ones that I want everybody to remember. This is another example of a junctional scotoma. In this particular case, you have more involvement in the left eye, but you can see you have this predominantly superotemporal effect in the other eye. So the classic bitemporal defect, nobody is really going to miss, but you want to remember that they're not always congruous. They may be incomplete. They can be unilateral if it's just at von Willebrand's knee, which is right at the anterior chiasm. And those can cause a junctional scotoma. And some of these patients may have hormonal imbalances if they happen to have a pituitary adenoma that's causing this compression. And in these patients, the workup is going to be a contrast MRI with attention to the chiasm. And in any patient, of course, if they're initially presenting to us, they typically may be complaining of some vision loss. You want to get a baseline OCT to help kind of determine prognosis and follow these patients. So with the management, the first thing that I've written here is a very specific situation. So this would be if the patient maybe had an incidental pituitary tumor found on exam, they've been sent to you for a visual field to see if there's a defect. They have a normal visual field and they're, you know, the plan is just to follow them, maybe to treat them medically. They're not going to have any type of surgery. In that situation, you're going to do a visual field every 6 months. If the patient has a resection of a pituitary tumor, you're going to get a post-surgery field, and then you're going to monitor that post-surgery field. Vision loss from compression can improve after resection. And sometimes the OCT helps you think about whether that's going to happen. If there's significant RNFL loss on an OCT prior to resection, the vision may not improve. And I'm just going to show you guys an example because I just saw a patient with this come in to see me last week. And this is not a new patient, but this is a patient who was 23 years old, had a pituitary adenoma that was diagnosed about 7 years ago, and he had surgery. And this is his OCT right now. And you can see the right eye has quite a bit of thinning, and there's a lot of loss of the GCC. And in the left eye, mostly nasal thinning. And also on the macular analysis, you can see this very nice following the vertical midline loss of GCC nasally. And this patient, vision in the right eye is 20/50 and 20/20 in the left eye. And you can see that his visual field shows that he still has quite a bit of loss in the right eye, which is the eye that had that RNFL loss. Not so much in the left eye. And again, on the OCT, you also see that. You see that, sure, you see that GCC loss temporally, which corresponds to this GCC loss nasally on the OCT. And you see that corresponding to this temporal defect. So very nice correlation between OCT and the visual field. So in conclusion, most of the things that we are concerned about in our clinic at worst cause vision loss, and that is appropriate. We're eye care specialists and we're really worried about vision loss. But there are a few conditions that can be fatal if they're missed, and they potentially could present to one of us first. And so the few things I want you guys all to remember is refer all patients with a partial or a complete third nerve palsy for urgent CTA. Order GCA labs on every patient over the age of 50 who comes in with an ischemic optic neuropathy. And I've added a couple of things here because these are more uncommon things that can happen with GCA, but they're possible. So diplopia, CRAO, or amaurosis. So you do want to get GCA labs on these patients. Rule out a carotid dissection in any patient who comes in with an acute Horner syndrome. So send them for that MRI, MRA, head, neck, chest. And be wary of atypical temporal field defects. And it's possible you could save a life. So I just want to
The next talk is going to be from Dr. Werner. And I don't want to embarrass Dr. Werner, but we're going to embarrass her a little bit anyway. I just wanted to talk for a second about refractive surgery co-management. Dr. Werner is our LASIK and refractive surgery specialist. We all think she's the best refractive surgeon in all of Colorado. We might be biased, but I think we all agree. Just a couple things we wanted to real quickly talk about. I think you know, Dr. Werner definitely doesn't run a quote LASIK shop, sort of unquote. And she really, I think one of the big differences is the individual care she gives to every patient, and really works with them to understand their needs and what they need. Is LASIK right? Is PRK right? Is an implantable column or lens right? And we also understand how much chair time this takes for you, our referring physicians. And so we definitely like to participate in co-management, and we do a 30% LASIK co-management fee. So if anybody is more interested in learning more about LASIK co-management, please just send me or Priscilla an email. And I think one of the other things we wanted to share real quick, which I think most LASIK surgeons might not share and just sort of talk in the aggregate, is these are Dr. Werner's real results, which we think are awesome. So at 1 week, 80% of the patients are uncorrected 20/20 or better at 1 week, which I think is pretty amazing. And then if you look at the 1 month, we have a 90% uncorrected 20/20 or better, which is a couple percentage points higher than a recent 2013 FDA outcome trial. And I think one of the things to highlight is these are really all of Dr. Werner's patients, whereas that FDA outcome trial was limited to a maximum of -4. So these are really looking at those higher myos, which are harder to hit. And then 97% of her patients have an uncorrected visual acuity of 20/25 or better at 1 month. So we think she's the best, and hopefully her patients think she's the best as well. And we'd be happy to talk to you guys more about LASIK co-management. And Dr. Benedict points out that she's so confident in her LASIK skills that she actually performed LASIK surgery on her husband a week and a half ago, and he's doing great. Okay, so presentation number 3 is going to be corneal ectatic disorders, keratoconus, and collagen cross-linking with our very own Dr. Werner. Somehow, despite our best attempt. Okay, now you should go with point.
Okay. Okay. Am I unmuted?
But we're not sharing your screen.
Am I unmuted? Can you hear me? So I'm still pointing over here. Okay. Okay, so hi, I'm Amy Werner. As Dr. Kanoff pointed out, I'm the cornea external disease and refractive surgeon with the practice. And I don't want to come off as a cowboy. I'm really not, but my husband has been slowly wearing me down over the last 5 years to do his LASIK, and he's very happy. So yes, it's definitely something I believe in, and I would obviously operate or suggest LASIK for my own family members. So I'm going to be talking today about keratoconus and corneal ectasia, and more specifically on collagen cross-linking. It's something that I'm actually very excited about and very passionate about. I feel probably how the retina surgeons felt when anti-VEGF was approved for wet macular degeneration. So we really have something for keratoconus management that's going to be a huge paradigm shift in treatment. And you'll see why I'm so excited about it here later on in the talk. So first, the last CE, felt like I was 1,000 months pregnant. Since then, we had Fitz join our family on March 19th at the beginning of the pandemic. So there's been a lot of ups and downs in 2020, but he's definitely been positive. So I thought you would appreciate this picture here on the 4th of July with my oldest, Bror, wearing his safety glasses.
he can't do anything remotely dangerous without his safety glasses. And this is how my oldest feels about the pandemic, and sometimes about having a younger brother that takes up attention. All right, so I embedded a little video here that we're going to skip. But this is Stephen Curry. So I'm from Florida, and I went to medical school and did my residency at the University of Florida, but I went to college at the University of North Carolina. Stephen Curry played for Davidson, which is a smaller team in North Carolina, and UNC is not University of Northern Colorado, but University of North Carolina. So he played on a smaller team in North Carolina, and they made it to the Elite Eight in 2008. And then he plays professional basketball now, but he suffers from keratoconus. So this is, we can come back to it at the end if there's time. But essentially this is like a newscaster talking about how, he was fit with his new scleral contact lenses, and now his point average is going up and he's more accurate. And he talks about how, it happened so gradually that he did not realize that his vision was blurry. So as far as I know, he hasn't had any collagen cross-linking, but he definitely has had a large improvement with the scleral contact lenses. So I think this condition is gaining a lot of improved education, and people are hearing a lot more about it. And lay people are hearing a lot more about it. So an outline, I'm going to talk about corneal ectasia and some of the honorable mentions, like keratoglobus, pellucid marginal degeneration, and post-LASIK ectasia. If we're performing LASIK or following LASIK patients, which most of us are, we need to be, able to look out for post-LASIK ectasia. I'll talk a lot about keratoconus, and then the treatment of progressive ectasia, and a lot about the paradigm shift in treatment where, first glasses, then contacts, then scleral contacts, observation, observe more, until unfortunately these people would, fortunately or unfortunately, these people would end up with a PKP, which, looking at this photo here to the right of this perfect PKP, you can barely tell that it's there. There's no neovascularization of the cornea. I mean, this is one of the reasons why, I wanted to go into corneal surgery. But I'll talk more later about how this maybe is not, it's a success, but maybe it's not a success for these early keratoconus patients that will eventually go down this route. I'll talk a lot about collagen cross-linking, and then some interesting new directions in keratoconus treatment and refractive surgery, and then follow up with some case examples at the end. So corneal ectasia is defined as a progressive thinning and steepening of the cornea. There are these three conditions, which, some people are lumpers and some people are splitters. But these keratoconus, pellucid marginal degeneration, keratoglobus may represent variations in the same phenotypic expression. Posterior keratoconus, I don't see all that often, and post-LASIK ectasia is one of the ectasias as well. So a quick note about pellucid marginal degeneration. It's uncommon, bilateral, unsure of the etiology, and what differentiates this between keratoconus or from keratoconus is the max area of protrusion is above the maximum area of thinning, similar to a beer belly. This presents in the 2nd to 5th decade of life. Keratoglobus, unlike pellucid and keratoconus, is a condition that people are born with. It's rare, bilateral, non-inflammatory. I've never seen it. The thinning is globular rather than conical, and the cornea is uniformly thin and steep to the limbus with additional thinning at the limbus. It's not associated with atopy, unlike pellucid and keratoconus, and there's a poor prognosis for penetrating keratoplasty, because if you can imagine, you have to use a very large graft close to the limbal blood vessels, which bring in immune cells and can lead to endothelial rejection. One of the take homes about this is spontaneous rupture has been reported, so it's very important for these people to wear eye protection, and corneal hydrops is rare. So post-LASIK ectasia, I have seen usually, 10, 15 years out from LASIK, and I haven't had the unfortunate experience of inducing post-LASIK ectasia yet, knock on wood, and hoping that some of the newer screening mechanisms will make this rare condition even more rare. It has been reported after LASIK, PRK, SMILE, which is small incision, lenticular extraction, radial keratotomy, and there are even some corneal specialists that believe that a form of ectasia can happen after LRIs or limbal relaxing incisions. So post-LASIK ectasia was first reported in 1998. The incidence ranges from 0.04 to 0.6%. And essentially it's from a reduction in the biomechanical strength, resulting in insufficient stiffness to maintain the corneal shape and integrity. It's more common to present as a unilateral condition in contrast to keratoconus, and in contrast to keratoconus, it has a later age of progression. So the anterior 1/3 of the cornea is stronger than the posterior 2/3 because this is where the keratocyte density is the greatest, and that's where the LASIK flap goes. So 110 microns, you're cutting the cornea there, and that anterior 110 microns is no longer contributing to the structural integrity of the cornea. So there are a couple of theories about why this happens, and there's probably some truth to all three of them I have listed here. So sorry, that's the next slide. More on association. So in decreasing importance, the risk factors for corneal or post-LASIK ectasia, the first one is abnormal topography. So looking back 50% of the topographies were abnormal. Maybe not diagnostic of keratoconus, but they were abnormal asymmetric, followed by a low residual stromal bed, followed by younger age, and followed by lower preoperative thickness, followed by high myopia, which also correlates to the low residual stromal bed. Young age was very...
So we have a quick question from the audience. So the question is ectasia less common with LASIK than PRK because the ablation is being done deeper with LASIK?
It is actually, there was a talk about this at the American Academy of Ophthalmology conference a few years ago, and it is slightly lower, but it definitely is not negligible with PRK. And I think people get a little bit more comfortable with PRK. But it still happens with nearly the same amount of frequency. And I can look into the exact numbers, but it's more common than you would think. So young age was the only thing that kind of differentiated between the folks with and without abnormal topographies that went on to develop ectasia. And these numbers surprised me when I was looking them up. So approximately a quarter of people that will develop ectasia will develop it by 3 months after their refractive procedure, half by a year, and then 80% by 2 years. Most of the folks that I've seen here that have developed ectasia are at least 10 years out from their refractive surgery. Questions I always ask patients that I'm seeing for refractive screenings: do you rub your eyes? So this presentation, you'll get so tired of me talking about people rubbing their eyes because I cannot, stress enough that this is super important to educate people about, to stop doing this. And if they want to be a candidate for refractive surgery, they absolutely cannot rub their eyes because they will give themselves ectasia. And although not a standard exclusion criteria that I'm aware of, I always ask people if they have a family history of keratoconus, because I would consider this an absolute contraindication. I have a patient that I did collagen cross-linking on a few months ago who had post-LASIK ectasia, and his brother never had LASIK, never had PRK, never had any refractive procedure, and he also developed keratoconus. So was my patient going to develop keratoconus regardless of refractive surgery? We may not know, but I think there's just too much evidence that there is a genetic component to feel comfortable doing refractive surgery or LASIK, PRK, and patients with a family history of keratoconus. So some of the theories behind post-LASIK ectasia, again, some of these, there's probably some overlap with all of these. There's probably some truth to all of these. What was the patient going to develop keratoconus anyway, and they had surgery? Were they preoperatively weak, and then LASIK tipped them over the edge? Or were these corneas totally normal? They weren't weak, and they were weakened with LASIK, and then this decreased the structural integrity, and they went on to develop post-LASIK ectasia. One of the reasons why younger people are more at risk for ectasia is that natural cross-linking happens with age, and all of our tissues in our body, including our cornea, gain tensile strength as we age. So on to my favorite, keratoconus. So keratoconus is a blinding progressive disease. But progression is non-linear. So the younger you are, the more likely you are to progress. But we cannot predict when people are going to progress. And I've had some patients progress in their 50s, even after the age that you would think that they would be cross-linked, naturally cross-linked. So there's thinning that develops into a cone shape. It's usually infratemporal. It's mostly bilateral, but asymmetric. There are some rare unilateral cases of keratoconus. You can develop myopia, irregular astigmatism, and eventually loss of best spectacle corrected vision. There are breaks and fragmentation in Bowman's layer, which kind of leads to this lacy subepithelial haze that I'll show you pictures of later. You can develop breaks in descemesan membrane, leading to corneal hydrops and acute swelling of the cornea. The putative locus for keratoconus is thought to be on chromosome 21. Folks with Down syndrome have an extra chromosome 21, and these people are 20 times more likely to develop keratoconus. It's much more common than we previously thought. So the old numbers would say 1 out of 2,000 people have keratoconus. A more recent paper from the Netherlands estimated that 1 out of 375 people had keratoconus. And there's even a paper from Australia that says 1 out of 80 people have keratoconus. Almost always the endothelium is very well preserved, which has implications for keratoplasty. We'll talk a little bit about that later. And the onset is usually in puberty with progression to the 4th decade, but there's recent literature showing progression beyond the 4th decade. So the CLEC study looked at about 1,200 patients over 8 years. The age of enrollment was about 39 years old. There was no race predilection. Half these people were eye rubbers or admitted to being eye rubbers. So probably more that weren't admitting they were rubbing. 96% were bilateral and 13% had a family history, thought to be some autosomal dominant and autosomal recessive traits that could be activated by environmental stressors like rubbing. There was no sex predilection, and the average 8-year increase in corneal curvature out of these people that were already, average age 39 was 1.6 diopters. And a quarter of them had a Kmax increase of 3 diopters or more. And this is a picture of Rizzuti sign here. So you shine a light on the nasal cornea and you can see the cone light shadow here on the iris. And so this is a picture of this reticular lacy pattern from these breaks in Bowman's membrane up here. And you can see some void stria here, but these are all late findings on slit lamp. So associations associated with allergies, including vernal atopic keratoconjunctivitis. This makes it 3 times as likely. Speaking with one of my pediatric ophthalmology colleagues, I don't know if this is true or not, but she was saying there's a huge increase in vernal keratoconjunctivitis with the change in climate and warming, and allergies are much more common. So this may be theoretically one of the reasons why we could be seeing more keratoconus. It's very highly associated with eye rubbing. So eye rubbing has been reported, again, 50 to 70% of folks with keratoconus thought to be related to keratoconus because of the microtrauma associated with eye rubbing. And there has been known to be vigorous eye rubbing in folks with Down syndrome. Corneal hydrops is more common in people with Down syndrome. associated with defects in collagen and fibrillin, so Ehlers-Danlos and osteogenesis imperfecta and Marfan syndrome. I have a patient who I follow with bilateral PKPs. She's in her early 40s and had both PKPs over 10 years ago and is currently dealing with off and on rejection episodes. And then
So there was one question from the audience. Is the increased incidence in Down syndrome due to eye rubbing or genetics?
that's a really good question. And I don't know if we have the answer for that. I think that it's probably a little bit of both. We do know that in other types of developmental delay that keratoconus is more common. So I think that just the developmental delay and, not being able to control the rubbing contributes. But again, that chromosome 21, there may be some genetic link there. So these people are floppy. So 50% have joint hypermobility. Really interesting that 38 to 58% of mitral valve prolapse patients have keratoconus. And I often see floppy eyelid syndrome, obstructive sleep apnea. So they have floppy cornea, floppy joints, floppy eyelids, floppy palate. So all things to look out for. So interestingly, not an association, diabetes. So risk factors for progression, young age is the big one. We cross-link with age, those sulfur-hydrogen bonds turn into sulfur-sulfur bonds. The tensile strength of our tissues increase with age. Other risk factors, family history, eye rubbing, mechanical trauma, allergies, and interestingly, pregnancy. So there are some case reports and small case series that demonstrate progression in pregnancy, which may have implications for talking to our young female patients with keratoconus who are thinking about starting a family, that they may want to consider collagen cross-linking prior to pregnancy, where they will be, unable when they're pregnant or breastfeeding to undergo the procedure. Just some anecdotal stuff with the eye rubbing. We have these patients that take on a larger than life kind of memory in our heads. In residency, we had a patient who had severe unilateral keratoconus. He was a lawyer and, not necessarily an eye rubber, but his kind of nervous habit he would take his eraser on his pencil and just kind of like press on his eye. So he had severe unilateral keratoconus. So that was an interesting patient. And then a gentleman that was a bodybuilder and he would sleep on his bicep. So again, unilateral keratoconus. I think there's a question.
So there was a question from the audience. So why is corneal cross-linking contraindicated in pregnancy?
So, it's just hard to justify doing a lot of stuff in pregnancy. The drops, sure, I give pregnant patients steroids if needed in pregnancy and antibiotics in pregnancy. It's just off-label, and I think there are a lot of things that are probably safe theoretically for pregnancy that we wouldn't do because, God forbid, something happened related to or unrelated to the patient getting the procedure during pregnancy. It's just would be hard to defend yourself.
Well, and probably nothing's going to happen by waiting 9 months in terms of progression.
They can progress actually pretty quickly.
Oh, I stand corrected.
Yeah. Okay, so importance of early diagnosis. So again, there's this huge paradigm shift, and I love doing PKPs. It's one of the reasons why I loved cornea. But if I never had to do another PKP for keratoconus, nothing would make me happier, because these patients end up with morbidity from these transplants later on in life. So there's increasing complexity of contact lens fitting with disease progression as that cone gets deeper. And even though patients can get excellent corrective visual acuity with these lenses, it does not stop progression. And now we are able to stop the progression before loss of best corrected visual acuity. So we would like to diagnose early so we can avoid penetrating keratoplasty. So tools for diagnosis. These pictures are, these would be late findings, but you can see a Fleischer ring here, the iron line deposition around the cone, the base of the cone. And again, here's some void stria here. So on retinoscopy, commonly you'll see scissoring. The autorefractor may give you an error message. On keratometry, there can be distortion of Myers. You may notice that the spherical equivalent is trending more myopic. Their patients are getting more astigmatism, loss of uncorrected and best corrected visual acuity. Diagnostic tools include topography, tomography, which is less likely, we're less likely to have these in our offices, but it's great because tomography, like a Pinacam or Galilei, can give us information about the posterior cornea and if there's any posterior elevation in the cornea. And then something that's available in tertiary care centers and for research purposes is corneal hysteresis, which shows corneal deformation with pressure. This is used for risk stratification for refractive surgery in some research studies, because if you're more floppy, then you're more likely to develop ectasia.
What's the difference between corneal topography and corneal tomography?
So topography is the front of the cornea, so usually with placido disc based, and tomography is with Scheimpflug, so you're getting cuts of the front of the cornea and the back of the cornea from the, basically limbus to limbus, and you're getting information about the thickness as well as the anterior and posterior cornea compared to a best fit sphere. So late findings, you're going to see the slit lamp findings, the classic ones, and then decrease in best corrected visual acuity in spectacles. And something interesting, I was reading, seeing kids and being on the lookout for these outliers. So in the vision in preschooler study and multi-ethnic pediatric eye disease study, the rates of astigmatism over 1.5 diopters was pretty low. They estimated, or they had 6 to 17% had astigmatism greater than 1.5 diopters, and the majority of these were with the rule. So if you're seeing these kiddos, you may want to see them more frequently, get a topography, because they're outliers and they may be at risk for developing keratoconus or ectasia. So here are some examples of abnormal topography. So you can see a skewed radial axis or an asymmetric bow tie. So here you can see the axis is skewed towards oblique, even though it's not asymmetric. And here is asymmetric bow tie with a steeper inferior cornea. You can also have a steeper posterior cornea, steeper inferior cornea. It can also be steeper superiorly, and then here you have both. Oh, and again, you can tell these Myers are very distorted and irregular. So something interesting I also ran into is that 28% of children that present with stage 4 keratoconus compared to 8% of adults. So this is a 15-year-old, an example of his Pinacam. I just saw him on Friday. So his parents, their insurance changed and they didn't see their primary eye provider for a year or two, was doing great in his glasses, 2020 previously, and was seen this month. And now he has best corrected visual acuity 2025 in the right and 2080 in the left. So you can see here, this is an example of his Bell and Ambrosio display. This just highlights the cone here, the anterior cone on the anterior surface of the cornea and the posterior surface. And then here you can see it's stage 3 to 4 keratoconus. So this kiddo, we have more than enough information to say you need cross-linking yesterday. Like, we need to get you signed up immediately to prevent further progression. Didn't admit to eye rubbing. So not a lot of other risk factors we can control to prevent further progression. And I used to suggest cross-linking the eye that was worse first, but a lot of the studies on quality of life measures are in the eye that sees better, right? You want to maintain the best corrected visual acuity of both eyes. So I've started to suggest cross-linking in the better eye to stabilize it first. So more on the education. So stop rubbing. So I always ask patients, not do you rub your eyes, but how do you rub your eyes? And you would be, and I'm sure you are, I'm sure you're shocked when you ask your patients. And if you're not asking, you should. Because sometimes they'll take their, index finger and middle finger and just really get on in there with the heel of their hand, their whole knuckle just in there. And then my medical assistants always laugh because I'll gasp and say, you are never, ever allowed to rub your eyes again. Like that was the last time. You can also look at family members in the room to see if they're like shaking their head in the corner. Like, of course you rub your eyes, because sometimes these patients don't even realize that they're doing it. And you can really employ the help of mom and dad or spouse to remind this patient that they're rubbing their eyes, so they can stop, because I tell patients, it doesn't matter what we do. If you continue to rub your eyes, you will progress. We could cross-link you. We could give you a cornea transplant, whatever. You will progress if you keep rubbing.
So what about people with allergies? Because I know that's what caused me to rub my eyes.
Yes.
Before I started here.
Sure. So, so the question was, what about people with allergies? So it's really important to try to figure out what the cause is. So if the patient has allergies, do they need to be on cromolyn twice a day? Are they rubbing because they have dry eyes? Do they need to start artificial tears? So yeah, I totally agree. It's important to try to figure out the cause. I've even suggested, if the patient has rhinitis and other signs of allergies, to actually going to an allergist and talking about allergy shots to help prevent eye rubbing, especially if they have all these other sequelae of allergies. And then you also want to ask about sleeping. Do they sleep on their bicep? Are they pillow divers? They may need to wear sleeping goggles. It's pretty annoying to have to wear sleeping goggles, but if they're going to be rubbing their eyes into their pillows, it's also another time when they're going to have mechanical stress on their cornea that could lead to progression. Is there a question? I thought I saw one. No.
What do you consider children?
Yeah. Under 18. The question was, what do you consider children? And I would say under 18.
So there is a question.
Okay.
So the question is, the few patients I've referred for this have had a bilateral same-day procedure, but in your talk, you're referring to doing cross-linking on the better eye first. What are the thoughts on doing it bilateral same day versus how far apart would you do the eyes? Great question. Thanks.
That is a really good question. I think that one day we will get to bilateral same day. And I'll talk about more of that later on with epithelial on cross-linking, which is not yet FDA approved. Currently, the FDA approved protocol is epithelial off cross-linking, which it takes some time to heal from, and it takes a few days to a few weeks to get the best corrected visual acuity back, sometimes even longer than a month. So that's why I prefer to do one eye at a time. Also the risks are small, but there are risks similar to cataract surgery. We don't like to do both eyes the same day because of course there's a risk of infection. And I usually wait until the eye that was operated on is seeing as well as it did before to move on to the next eye.
So do you feel like, so that's the current standard of care, is sort of doing each eye individually at this point?
In the US, the standard of care is to do each eye separately. There are trials for epithelial on, which they're doing a lot of in other countries. I'll talk more about this later. And I do think that that will eventually be the standard of care, is bilateral epi on with a much lower threshold for treatment, given that you would potentially avoid some of those risks with infection, et cetera.
Great, thanks for the questions. These are excellent questions.
So these are just some pictures of, you can see the cone here on the left, an apical scarring with retroillumination. And then this is an example of corneal eye drops. So when to refer early if there's a concern, so they can get baseline testing. And due to the recent paradigm shift in treatment, it's really helpful to have in referrals the previous refractions with the best corrected visual acuity, uncorrected visual acuity, manifest refractions, Ks, topographies, and all of this will help support collagen cross-linking and help support the rationale for it for the insurance company. I remember, in fellowship, it's really cool because when I started training, cross-linking was only in Europe. It didn't exist in the US. It was unavailable. And then in fellowship, we did a few cases, but I remember writing letters to the insurance company, telling them, attaching research papers, like this is why you should cover it, and still having a really hard time. And then, last year, more carriers were covering it, but they had all these criteria that you needed to meet, like the K-max had to increase a certain amount, best corrected visual acuity had to decrease. And it seems like each year there is less and less criteria that needs to be met. So this is a copy of the policy down here from one of the more stringent providers, Cigna. So you just have to convince them that the keratoconus is progressive and meet these criteria. So there's definitely less hoops to jump through as far as confirming progressive keratoconus than there used to be. So I love this quote. The goal of keratoconus treatment should be the prevention of sequelae, not just the stabilization after loss of function. So this is a box, outlining the, as you all know, the conservative to more invasive treatments for keratoconus, more invasive being keratoplasty, less invasive collagen cross-linking and corneal ring segment implantation like Intacs and Ferrera rings, and then the things like less invasive, way more conservative spectacles, contact lenses, and our contact lenses are getting so much more advanced and comfortable that patients usually do very well on these, but it's not going to stop the progression of disease if they're progressing.
So a couple questions coming in. So another question about the same-day corneal cross-linking. Would doing same-day corneal cross-linking cause the patient to be visually impaired for a few weeks while waiting for things to heal?
If I think the answer is different if it's epi on or epi off. Epi on, you still have some decrease in visual acuity, but less than epi off.
So for the current FDA-approved epithelium off, it would cause pretty significant visual disturbance for the patients.
Yes. Yeah. And I'm going to kind of speed through.
So there's one other question. What percentage of patients with keratoconus progress?
So this is a tough question, and it really depends on age. And I don't know if I have an answer for you on that. I do know that one of the papers I was looking at, 11% to like 25% of people with keratoconus will go on to need a penetrating keratoplasty. This is before cross-linking, the event of cross-linking, but that's a difficult question. I can look more into that. So, all right, so I'm going to speed on. So penetrating keratoplasty, really lucky to have it, but the average lifespan is 20 years. The American Academy of Ophthalmology estimates that the PKP, the first PKP cost an average of $20,000 to $50,000 of US healthcare dollars, which seemed like a lot at first, but thinking about it, yearly exams, rejection episodes, et cetera, this actually seems like it may be a conservative number. So PKPs are the most successful solid organ transplants. Okay. And here's the number I just quoted. So 11 to 27% of patients with keratoconus will eventually require a corneal transplant. And, graft failure, 25 years, 83% of PKPs fail. So that's a huge number for these people who are in their 20s and 30s. They're going to live a very long life, and they're going to need multiple procedures. And we know that each transplant, the failure rate goes up, and these are the patients I lose sleep over. My bilateral PKP patient with Ehlers-Danlos who had to transplant 10 years ago, and she's had rejection episodes. Like every time I see her on my schedule, I get anxious. Like, is she going to be rejecting? Like, what are we going to do? I mean, she's 40. She has to maintain good vision for many, many years to come. So not necessarily a success. I cringe when I see these patients because, you know, it's how do you treat this? It's tough. So a quick note on deep anterior lamellar keratoplasty. So you leave Descemet's membrane behind and you decrease rejection episodes. So it's technically challenging. And if you want to hear more about that, then ask me. Interstromal corneal ring segments were used very frequently. I was taught to use them to improve contact lens fit and comfort because you are centering up the cone. But with the new contact lenses, people are able to tolerate them very well. And at least I don't use these that often. Question? Yeah.
How often are you following patients now that cross-linking is over? How often do you follow them and follow the imaging?
So the question is, how often are we following patients now that cross-linking is an option? It depends on the age. So, you know, and there are people that say if you diagnose someone with keratoconus under 22, I mean, this is a condition that you're not born with. So by definition, they're progressing. And there are people that suggest just automatically going to cross-linking, which I think is very reasonable. If they are in their 30s or 40s and haven't noticed any change in their prescription, maybe every 6 months at first, and then kind of titrating, but educating them that if they notice a change in their vision, they need to come back in to get repeat tomography.
Are you able to, if you have a young patient who presents to you for the first time, for insurance purposes, do you have to have imaging to prove that they progress? How do you?
So you
Okay.
So a change in refraction, a change in, oh, sorry, the question was for young patients, how do you justify to insurance for cross-linking coverage? Do you need imaging? So not necessarily. So a change in the spherical equivalent trending more myopic or astigmatism, you know, Kmax is always helpful to have, but you don't necessarily need imaging, and you can use numbers from the outside referring office. So I love this slide. I love this picture. This is from the proof of concept paper by Theo Seiler in the late 90s. So this is a porcine cornea that's been cross-linked. It's very rigid. It's kind of just curled up, and this is like a flaccid porcine cornea right here. And this is a picture of the FDA-approved Avedro unit, which this picture was taken by Joel Myers, Dr. Joel Myers. We recently got this actually last week. So we got the unit last week. Here's a little bit of the indications. And as insurance coverage has gotten much better, most people will have insurance coverage for the FDA-approved unit. We have the Peschke unit already. The previous cornea provider had the insight to purchase this unit that's commonly used in Europe prior to FDA approval in the US. And it still works very, very well. But currently the only FDA approved machine is the Avedro unit. And I'll go into that because they did a rigorous FDA trial here back in 2000 that completed in 2017. So collagen cross-linking makes the cornea 3 to 5 times stiffer. The proof of concept paper was in the 90s by Theo Seiler. Their paper on progressive keratoconus came out in 2003. 23 eyes of 22 patients were treated and they all stopped progressing. 16 of the eyes actually showed signs of progression. And then there has been an explosion in collagen cross-linking studies since this 2003 study. The one in the FDA trial was completed in 2017 by Avedro, and it included 205 eyes of progressive keratoconus and 175 eyes of progressive post-LASIK ectasia. These patients were randomized into treatment and non-treatment with the Dresden protocol, which was from the 2003 paper, and we'll talk about that here on the next slide. But the Kmax decreased to 1.6 diopters in the treated group, and it actually steepened 1 diopter in the non-treated group at 12 months. So an overall difference in 2.6 diopters, which was very, very, very statistically significant. When I talk to patients, I tell them this is a chemical reaction. The ingredients are riboflavin or vitamin B2, UVA light, and oxygen. and this creates bonds between the collagen fibers. Actually, it's the proteoglycans in between the collagen fibers, but essentially oxygen becomes singlet oxygen in a free radical, and these free radicals contribute to the cross-linking between the proteoglycans. And this is an excellent website, livingwithkeratoconus.com, that was set up by Avedro with more information, and patients can go there to see who provides cross-linking and see what their insurance coverage is. And this is just a very simplified picture of increasing the cross-linking bonds between the collagen fibers. So the procedure is removing the epithelium in a 9mm diameter, soaking the cornea with Photrexa or riboflavin for 30 minutes, 1 drop every 2 minutes. You check for flare in the anterior chamber, similar to fluorescein flare, to indicate that the stroma is saturated with riboflavin. You check the corneal thickness because it needs to be greater than 400 microns. It's thought to decrease endothelial toxicity, although this may or may not be a hard and fast rule. If it's not 400 microns, I haven't had a patient that I have not been able to swell to 400 microns with extra drops, and then you irradiate for 30 minutes, applying Photrexa every 2 minutes to prevent desiccation and a decrease of the thickness to lower than 400 micrometers. So this is the Dresden protocol. So one of the reasons I was really excited, so this is my 15-year-old progressive keratoconus patient who was cross-linked, and a year later, hold on. So this is in January of 2019. His Kmax was 60.9, and now his Kmax is 59, with the same excellent corrective visual acuity in his scleral contact lenses. This patient was a huge bummer. He came in, he's 32 years old. The best he sees is 20/70 with a scleral contact lens recently fitted. He is very, very thin, 290. So he's, got a lot of medical comorbidities. He's not really a candidate for cross-linking because of the thickness, and doing a penetrating keratoplasty on him would be a huge deal given his medical comorbidity. So, I had the unfortunate conversation of saying you shouldn't be driving. So note about insurance, this is not something that you should have to worry about. But again, this is something this is a very successful procedure, and the US, like with a lot of things, is a little bit behind the times, but it's FDA approved, and now insurances are covering the procedure. We have the new unit, but we kept the old unit, the Peschke unit. The new company, so Avedro was the FDA approved unit, and the company was acquired by Glaukos, so they're rebranding it as an iLink procedure. And they seem to be very responsive and helpful in getting this procedure covered with folks without insurance, patients with Medicaid. They seem like they're very willing to work with us to make this happen for people. But it's just important for us, for the patient to be able to get the procedure no matter what. So we're still able to offer the off-label treatment with the Peschke unit if this ends up being the best thing for the patient. So, we used to tell the patient, I don't care where you get this done. It's just important that you get it done. If it makes more sense to get it with us, then get it with us. If it makes more sense to get it with the FDA approved unit, which we did not have last year, then that was okay. And we used to have a lot of people come back to us and say, actually, it's cheaper to get it done with you. But we've seen less and less of that. So insurance, it's a good sign that insurance is covering it. And now we can offer it pretty uniformly to folks, regardless of Glaukos helping us out. And epithelial on is not currently FDA approved. The Avedro/Glaukos is currently in a phase 3 trial for epithelial on with some accelerated protocols for cross-linking, meaning the UVA light being more intense for not as long, so shortening the procedure. So one of the reasons I was really excited to do this presentation, there's so much information about collagen cross-linking, and I was really excited to kind of look into some of the recent papers to look at epi-on versus epi-off versus standard versus accelerated. And I came out more confused than I went in. So you can see here, this is my PubMed search for collagen cross-linking. So just a giant explosion of research, and there were, 1,800 papers. Most of these are really small studies of 20 patients. So there are some great successes with epithelial on and accelerated protocols, but they're really small patient numbers. And one of the things that's really hard to draw conclusions from these studies because they don't all use the same definition of progression. They have short follow-up, and there are so many different ways to do epithelial on cross-linking. There are different types of riboflavin. So I'm really looking forward to the FDA trial, the phase 3 trial that Avedro/Glaukos is putting on to see what it shows us. So what to expect postoperatively, most patients reepithelialize in 3 to 5 days. Vision can actually go down at a month as there's reactive epithelial hyperplasia, and actually the Kmax can increase. If you're thinking about it, you're taking this cornea that has a cone and there's been epithelial remodeling around the cone. You're removing the epithelium and you're kind of unmasking this cone, and the epithelium has to grow back and remodel. Patients can start wearing their old scleral contact lens at 1 month, and then the scleral contact can be refit at 3 to 6 months. We see a lot of change in the first 3 months, but there can be stabilization up to 12 months. And there's some evidence that even up to 2 years, the cornea can change. It's important to tell patients we're doing this to stabilize the cornea, not to reverse damage, although that is a very common side effect, that the Kmax can decrease, the vision can increase, especially the younger you are, we see this more. So complications, so delayed epithelial healing, especially if the patient is a rubber. I had one patient that it took maybe 2 weeks to heal instead of the usual 3 to 5 days. And he was a rubber. There are things we can do to optimize the ocular surface prior to collagen cross-linking, similar to PRK, that will decrease the risk of these things. So putting in plugs, using artificial tears, not rubbing. I've had to use Procera on one patient to get them to reepithelialize. Never seen it, but anytime we're making an epithelial defect, bacterial keratitis is a risk. Corneal haze is pretty uniformly seen in the cornea after collagen cross-linking, and I tell patients this is a good thing. It's very, very rarely visually significant, and it goes away, usually by about a year. And if we're doing this procedure in patients that have had LASIK, they can have something similar or identical to diffuse lamellar keratitis. So you need to look out for this and maybe increase steroids. They may need a flap lift and irrigation if the inflammation is getting severe. So when is it too late for cross-linking? If the thickness is less than 330 microns, it's probably too late. We can usually swell corneas that are 350 to more than 400 microns. If there's severe scarring or opacity, 5 minutes. Neurotrophic keratopathy, autoimmune diseases, pregnancy and breastfeeding, or active corneal hydrops. So let's see. So this is, now we're on to interesting cases. So I can answer, I think there's a question. Is there? No? Okay. Oh.
Okay, so question is, could you talk more about age and cross-linking? Is there a point where it's no longer helpful after a certain age?
So, you're more likely to progress if you're younger, but there are case reports of people progressing at a later age. I tend to recommend follow-up less frequently, but it can still happen. So I just tell these patients, if you're noticing a big change, come back in sooner. I'll follow people for, there's no cutoff. There's no cutoff for age, I guess is the short answer to the question. And I think as cross-linking kind of evolves and there's eventually an epithelial on protocol, I think it'll make more sense to cross-link older folks because the risk will be so low that the risk-benefit profile would just make sense to cross-link them because progression's not linear. We can't tell you, oh, you're 50 or 60, like you're definitely not going to ever progress. So I don't know if I answered your question. All right, so these are some interesting patients I've run into the last few years. So this is a 59-year-old male with bilateral LASIK 20 years ago. He's referred for post-LASIK ectasia, and you can see here that his Pachy is actually really thick. He is 666 in the right eye and 657 in the left. So what in the world is going on? I mean, you can definitely tell this is the front of the cornea, similar to topography, and this is the posterior float. So you can tell there's definitely a cone here, more so in the right eye than the left. And this is a specular microscopy. So Fuchs and keratoconus, and this would be post-LASIK ectasia, have been described. And this, you can definitely tell in this anterior segment OCT that he has some thinning down here in the cornea. So what in the world do we do? He also has an early cataract. So I had a long discussion with this patient that cross-linking would probably be the first thing, but I'm going to worry that his endothelium will decompensate with cross-linking. He's definitely going to eventually need a cornea transplant, followed by a cataract surgery. So a lot of stuff all at once, but we would love to preserve his cornea so that he doesn't have to worry about endothelial rejection in the future. So he's still seeing quite well with his scleral contact lenses, amazingly, 20/50 and 20/30. So we'll see him back for follow-up here in a few months.
So a question, how much regression in keratoconus have you seen with corneal cross-linking?
So the Kmax average, I think, was about 1.6 diopters in Kmax decrease in the FDA trial.
So are there any other last minute questions for Dr. Werner, or else we'll unfortunately cut her off and move on to keep everybody on time. Okay, well, if any more questions pop up, we can certainly answer those at the beginning of the next session. By Dr. Werner. Yeah, so in terms of corneal cross-linking, so we just, as she was mentioning, we just recently purchased the FDA-approved corneal cross-linking system from Avedro and Glaukos. And we're now able to offer treatments to all patients, both through insurance or self-pay. And just as she was mentioning, even though Glaukos, really their goal is to buy these old Peschke machines and destroy them so that everybody is forced to use their system. We decided to keep our Peschke system so that make sure we can offer treatments to patients regardless of their ability to pay and access to insurance. So one other interesting opportunity is that through Glaukos, they're offering a heavy discount on corneal topographers to optometrists if they're interested in purchasing them. And you always have to think to yourself, well, you know, what's the motivation for a device company to offer discounts? And it seems obviously their motivation is the more keratoconus that's detected, the more use of their system, and then the more money they're going to make. However, you know, I think in this case, it really aligns nicely that, you know, if we are able to diagnose more patients with keratoconus early, we're able to do a great intervention for them and potentially save them needing a corneal transplant. So in this case, all of the interests seem to be well aligned. And some interesting studies that they found that 70% of keratoconus is initially diagnosed in primary eye care and in optometry practices. And so what they're offering is a TopCon CA800 topographer, normally is a price of $14,790. And through their subsidizing of the technology, they're offering it for $8,990. And one of the interesting things is that it specifically includes some keratoconus probability software, which can be a win-win for optometry practices and you guys to be able to diagnose patients better, and also for patients to get this treatment sooner. So if you have any questions or you're interested in learning more about that program, go ahead and send me an email and I can get you in touch with the reps and get you a lot more information about that. So our last presentation is periocular dermatology by Dr. Myers, and we will turn it over to him in just a sec. We want to show the other screen. Okay, so you should be able to point on that screen.
Very good. Well, good morning, everyone. I want to thank first off all the presenters today, and most especially Priscilla for organizing this. Good job. I think it's going really well. And thank you to Dr. Canoff for doing a lot of the organization and AV sort of stuff that makes it possible. Thank you. And so also a big thank you to Priscilla, because when I first submitted my slides to COPE, I think they were going to have a stroke because there were so many, and she managed to arm twist them into letting it happen. The bottom line is that paraocular dermatology can encompass all of dermatology, and there's not enough time to do that. So what I'm going to be asking Priscilla to do is to send an outline of the extended version of this so that everyone can have a lot of the things that are less common. And I want to keep this practical and make it pertinent and not go off on all kinds of esoteric things, which most of us will never see in our lives, or I might see rarely, but I want to keep it relevant.
What we'll do, sorry to interrupt, is that we're going to post all 4 of these presentations on our website because they are so large to email. It would make it very hard to email. So we'll post them on the website, and we're also going to post a recording of this session on the website as well. So we'll get you a link to where all these presentations are through Priscilla.
That sounds great. So before we get started here, I want everyone at home, I was going to do a whole bunch of questions. And when I realized doing this at home that Zoom only allows 25 questions per seminar for webinar, I didn't want to lose any of Dr. Parik's, and I didn't want to blow up Zoom. So what I want you to do is on your own at home, you keep a tally, because we're going to do a pre-test and a post-test, and hopefully the post-test will show that we've all learned something. Even people like Dr. Benedict, who his general view of oculoplastics is, do the eyelids block my view of the retina or not? So continuing on, the basic goals here are a quick review of the basic skin anatomy, understanding the skin physiology, recognizing paraocular skin pathology, and the basic review of some of the treatments and management of some of these conditions. And so continuing on, here's the pre-test. So what I want you to do at home, and for all those here as well, just to test yourselves, is the big question is going to be real simple. Is it benign or malignant? So we'll spend about 10 seconds on each one of these. And so, so I'm getting a weird thing happening here just in my screen. So I'm supposed to be looking here. This one, correct?
Yeah.
Okay. And then that's the next one. Got it.
Yeah.
Okay. So just the first one here, big question is benign or malignant. Next one, benign or malignant. Keep your tallies. Next one, benign or malignant. Next one, benign or malignant. Next one, same thing. I'm hearing from the crowd, that looks bad. Doesn't that one look bad? Benign or malignant here? Benign or malignant? See, this is why there's people like me, because the crowd here doesn't necessarily know. Continue on, benign or malignant. And benign or malignant. This one's for Dr. Kodatek, benign or malignant. He knows the answer though. Continuing on. Benign or malignant. We're getting close. Couple more. Benign, malignant. And again, we're going to go over all these at the very end. Okay, so the bottom line is none of us wants to miss anything important. And so all right, so basic review of skin anatomy. It's a multi-layered structure. There's the epidermis. The dermis in the eyelids is extremely thin, if not non-existent. There isn't any subcutaneous fat in the lids. And there's all kinds of little accessory glands that we all know and love, specific to the eyelids, sweat glands, oil glands, hair follicles. And the bottom line is something can go wrong with any of them. And here in the general concept of the epidermis, there's keratinocytes that migrate from the basal layer up to the surface. So there's a basal layer that can go bad, the surface layer, the squamous layers that can go bad. They produce keratin, which matures, comes to the surface, and the epithelial cells from the surface go through about a 6-week cycle before they are sloughing off. And down deeper, we have the melanocytes that produce melanin, and that's what absorbs the UV or as a natural sun blocker to protect the DNA. And then the dermis again in the eyelid skin itself, the thinner skin, there really isn't any dermis, but within the dermis, there are epidermal appendages, the dermal appendages, the sebaceous and sweat glands, hair follicles. And again, things can go wrong with any of these structures. Skin physiology, basic concepts. It's a barrier to bacteria and irritants from entering the body. And then there's more of an internal barrier with involved with thermal regulation. This is more for the rest of the body with vasculature providing for conduction of heat and regulation of temperature, and moisture for evaporation purposes. And basic concept in the world of cosmetics, we talk about the skin that you are born with. You have that until about the age of 30 or so. And after age of 30, you've got the skin you've given yourself. And so there's extrinsic factors that can cause challenges. There's intrinsic aging, infection, inflammatory and allergy, autoimmune disorders, and cancer that can all become part of issues that affect the skin health throughout the body. So clinical approach is first to get a thorough history. How long has the lump or bump been there? Has there been any change? Is the change more sudden, slower? Is there pain or itching associated with it? Are there cresting or ulcerations associated with lesion? Was there previous trauma, skin cancer, and skin type? When I say skin type, that refers to the amount of pigment of skin. You have the people who have what's called a Fitzpatrick type 1 skin type, where they're of Scotch-Irish ancestry. They have the milky skin, green eyes, red hair, versus the other extreme, Fitzpatrick type 6, which would be someone of, say, African descent, and you have all the skin types in between. So the darker the skin tone, the less likely pigmentation is going to be a pathologic issue. The lighter the skin type, the more likely the skin type is going to be a pathologic issue. So careful approach to any patient, ABCDEs kind of concept for any bump. Is there an asymmetry to it? What does the border look like? The shape, color, the size, the depth, and extra features, pearly surface. What does the margin look like? Are there ulcerations, umbilication, which is an indentation, warmth? Is there swelling, pain, so forth? And the big question is, how accurate are we in looking and evaluating these things beforehand? And there was a study back about over 30 years ago that lesions that were predicted to be benign, 2%, almost 2% were actually malignant. And those that were predicted to be malignant, actually 8.5% were actually benign. So the only ones who knows for sure whether it's benign or malignant is going to be a pathologist looking at it under a microscope. I have the advantage that I've got, 34 years of looking at things, so I'm going to have a better idea than a lot of people. And one thing that didn't make it on this is for those who don't have my phone number, I'll make sure that I do give it so that you can text me pictures of things so that if you have a quick question, you can always just run it by me less officially perhaps and save yourself and the patient some time and challenges. So common things are common. That's one of the rules of medicine. And so there's epithelial hyperplasia processes, skin tags, papillomas, seborrheic keratoses, cystic lesions, which I refer to as water balloons. A water balloon can be full of water. It can be full of something thicker. So that's how I think of cysts, inflammatory lesions such as chalazion, hordeola, allergic processes, and then melanocytic processes, nevi, moles. And so again, big question is this something benign or malignant? One of the biggest concerns that we all have is that malignant lesions can masquerade as inflammation or benign lesions. Sometimes malignant lesion will be blocking an oil gland, create a chalazion, and well, we're initially just seeing the chalazion when in actuality there was a malignant process that contributed to the original that contributed to the chalazion development. When it comes to skin cancers, 5 to 10% of them do arise in the eyelids, and statistically 90% are basal cell carcinoma. So one of the cutesy sayings was on a board question, if they show you a lesion that looks malignant on the eyelid, always say it's a basal cell unless you're 100% sure it's a squamous cell, because statistically you're going to be wrong. Male and female is fairly equal, and obviously older is more likely to be occurring than in younger populations. So there's a lot of different characteristics of eyelid lesions that can give strong clues as to whether the lesion is benign or malignant. So again, cysts are filled with fluid, can have white or yellow inside it, and not just be clear. Pigmentation is a common concern, and color changes that occur over time. Bleeding and scabbing are common issues that we'll see with malignant lesions. The rate of growth, it's in another slide later on, but most benign things, as well as malignant processes, do grow slowly. So that's not always a good indicator. Palpation characteristics, that's a very important one in that firmer type pearly lesions are oftentimes malignant. We'll get to that more so later on. Umbilication, what is umbilication? I mentioned it before. Umbilication is where there's an indentation in the middle. And despite the indentation here, it was delicious. So thank you to my wife for providing an excellent example of umbilication. So anyway, exceptions do occur. Nothing's 100%. The only thing I'm 100% certain of is that I'm pretty much 100% certain that I'm mortal. Beyond that, I'm pretty sure Dr. Benedict is mortal too, because he proves that to us once in a while himself. The rest of the people in the room, I'm not sure. They may be immortal. Anyway, so exceptions often occur. So cysts will often have clear fluid. They're frequently hydrocystomas. Again, think water balloon. You're looking at something and you get the light beam on your slit lamp narrowed, turn on high beam, and oftentimes you'll see it kind of glow with the fluid from inside. Some benign cysts can look suspicious if there's white or yellow coloration in them, and oftentimes they can have thicker contents. Malignant cysts, fortunately, are extremely rare. They're possible. So if there's other associated changes with them, if it looks unusual, you got to keep that in mind, that unusual things need to be further evaluated. So pigmented lesions, the rule is if you've got someone with a darker complexion, they are more allowed, so to speak, to have pigmented spots throughout their body. You get, again, the person with the light colored complexion who has a pigment, whether it's on the surface of their eyelid or conjunctiva, that is not allowed so much at all. And what we're looking for is growth, and something that has been there for 20 years and hasn't changed in size or color or changed in any way, shape, or form, we don't care so much about. But if it is changing slowly over time, it's important to have it evaluated. There's a variety of pigmented lesions that we'll see, and sometimes they're elevated, sometimes they're flat, sometimes they're slightly elevated and with variations in them, and sometimes they're deeper but small. So pigmented nodule, if this is something that's been there for 20 years, we're not going to be so concerned about it if it's not changing in size or shape. If the patient says, you know, this wasn't here 3 months ago, that's a whole different story. So again, history is really important on evaluating pigmented type lesions. Bleeding or scabbing often are seen with malignancies, and that can be from actinic keratoses, which are precancers, squamous cells or basal cells, and can occur with a variety of benign lesions. A lot of people, you know, as Dr. Vernon was talking about the eyelid rubbers, a lot of people, they just can't keep their hands off their face, off their eyelids. They got to play with things, and they'll rub, poke, prod, pull, and eventually create a problem. But when you see a patient like this, who's got recurrence of scabbing, crusting, that's of significant concern. You can see there's a lot of other sun damage throughout the tissues. Another thing that's very important is loss of lashes, and that's oftentimes associated with basal cells or squamous cell skin cancers. It can occur with benign lesions, with even with chalasia, but again, once the chalasia is gone, those come back. Trauma can occur. I've seen patients lose lashes permanently from things like even eyelash curlers. But this is a very important clue, and we'll get to this in a little bit more so. So here's a situation where there's some focal lash loss. That is never a good sign. And then you have someone who's undergone chemotherapy and they have diffuse lash loss. So umbilication, mentioned before, that's a hallmark of malignancy. We see it with basal cell skin cancers, keratoacanthomas, which is a rare type of growth, which technically isn't a cancer, but they are destructive. It can occur in other lesions too, which we'll go on to discuss later on. The tempo of growth, again, most benign and malignant lesions are slow growing. Explosive growth tends to occur with infectious type processes. You'll see this with the inflammatory conditions such as chalasia. Malignant explosive growth, again, is very rare and not something that anyone's likely to see. But, you know, if it does occur, again, that individual does need to be evaluated. So this is something that talk to this patient, that wasn't there 2 weeks ago. That's not going to be a cancer. We don't need to worry about that. This is an inflammatory infectious process. And this was actually a patient who had a nasolacrimal duct obstruction, chronic tearing for years, ignored it, developed a lacrimal sac abscess, which then ruptured into her face. And there's a reason why the textbooks say that if you have a nasolacrimal duct obstruction, you should have it repaired, as opposed to just ignoring it forever. Anyway, palpation, this is an important concept. Induration is a term for firmness. Firmness beyond the visible border suggests an infiltrative process, something that's going on that's likely going to be malignant. Again, the patient we saw here before, yeah, there's firmness that extends beyond, but this wasn't there 2 weeks ago. Basal cell skin cancer of this size would have been there for months and months and years before getting to be that large. In general, benign lesions will far more oftentimes have a distinct edge to them. Palpation, when you feel it, can be soft and spongy, non-tender versus firm, tender, and mobile. Again, the things that commonly will appear like something else are chronic blepharitis, chalasia, eyelid swelling for a variety of causes, and pigmented spots. So these are things that look, you look at it and it's not intuitively obvious what it might be. They're oftentimes masquerading as something more ominous, or sometimes things that are ominous masquerade as something less. Anyway, if you walk away from my presentation with nothing else, walk away with these things here in red, warning signs. So destruction of normal architecture. Benign things rarely destroy the normal architecture. And one of the biggest hallmarks of a malignancy is going to be a loss of lashes. Lashes are incredibly tenacious nature decided to put a lot of effort in keeping our lashes there. And so if the lashes are still there or growing through, this is really important, growing through the bump, the lump, that's far less ominous than something that has destroyed the lash follicles completely. Firmness beyond the visible borders. If there's firmness that's extending beyond what you can see, that's a nasty sign. Bleeding or scabbing. Malignant processes will oftentimes outstrip their blood supply, their healing abilities, and so they'll present as chronic ulcerations. And umbilication, basal cell skin cancers very frequently will have an indentation in the middle of them. Growth of a pigmented lesion, we don't ignore that. That's a very important telltale sign for a pigmented structure of any kind. So those are important ones. And oftentimes, despite those things, we're not sure, or I am sure, but I'm not going to take someone to an operating room and remove a good chunk of real estate from their eyelid or face unless I have the biopsy to prove it. So that is a definitive way to make the diagnosis. In general, broadly speaking, and the handout that you'll be having access to goes through a lot of these things, a lot of which are just really not common, but we divide skin lesions into different categories: vascular, infectious, inflammatory, allergic, neoplastic, whether it's benign or malignant, and involutional, which is due to aging changes. So vascular lesions, the common ones that we'll see are angiomas, which are small, benign vascular growths. They're common on the face, trunk, and they're treated with electrodissection or laser. It can also technically be a capillary hemangioma. And a lot of the things that I see, that you'll see, they fall into the category, for me, I'll say to the patient, if they don't bother you, they don't bother me. And this is something that's totally benign. It's completely cosmetic to remove, and there's nothing to do for it. Oftentimes, if something is growing, it's going to cause annoyance, irritation, and there's certainly justification to remove it for that purpose. Infectious processes, here's a very common type of situation, a wart. It's due to virus, and if we see that there's one there, I'll usually recommend it be gotten rid of so that they don't have to deal with more, because they can spread. So here's a benign type of umbilicated lesion, a molluscum contagiosum, and these are treated with excision. They are spreadable from one part of the eyelid to another part of the eyelid or the body, and it's important to get rid of these. We tend to see these in younger people. So we've all seen some patients with herpes simplex dermatitis, and we see these vesicles in the eyelids, and the last thing we want is for these patients to become one of Dr. Werner's neurotrophic corneal ulcer patients. So we want to be aggressive with treating these patients. And herpes zoster, remember, it's the varicella zoster virus that's reactivating, that was laying dormant in our nervous system, and it occurs in the dermatomal distributions. For those of you 50 and older, I strongly encourage you to get your zoster vaccines. Yes, it's going to hurt maybe a little bit. It might make you feel a little less, or for like most of us in the room here are nodding our heads, feel pretty crummy for a day or two. But boy, again, you do not want to become one of Dr. Werner's neurotrophic corneal ulcer patients. Not that she doesn't know what she's doing. She does a great job with these patients, but they don't do wonderfully no matter what. And it's something you definitely want to avoid. Secondary cellulitis isn't that common when patients have these. So continuing on with inflammatory, infectious kind of things, styes, hordeola, that's usually starts as a small pimple-like lesion at the lid margin. We've all seen these, and you hit them hard with moist heat, sustained. Again, the wet washcloths are worthless. It's got to be a heat sink that will maintain heat for a good 10 or 15 minutes. And depending upon how out of control it's getting, plus minus any antibiotic treatment, and hopefully it will resolve on its own or drain spontaneously. And if not, then that's part of what I spend a lot of time doing, is draining these. Chalasia, as we know, that's from the meibomian glands that are blocked, and it's a caseating granuloma, histologically speaking. And it's painless until it's painful. And some of them get names and zip codes associated with them. They're so large. So usually starts as a small pimple, and it'll be in the tarsal region there. And again, similar concepts that we all know and love with treating these. So pyogenic granuloma is where the body overdoes a healing type response, and it's trying to heal something that it doesn't need to or shouldn't have to. And so it's a exuberant healing response, not uncommon to occur with chalasia. Here's a patient I saw just recently, and they presented with this. This is a young child, and there's a spot on the lid that is a pyogenic granuloma. Again, it's an overabundance of the body's attempt to heal itself when it didn't need to. And if you look carefully here, you'll see there's a meibomian gland blocked on the contralateral side. And, I explained to the mother that, we need to make efforts at doing the lid hygiene, warm compresses. These can spontaneously disappear. That's the hope, because the last thing you want to do is take a kid to an operating room and remove something like that, because they're not going to hold real still for doing something in the office. You especially don't want to do it when they've got other lid disease going on. I've had a number of patients over the years where you take the kid to the operating room, remove something, and 2 or 3 months later, they have something similar elsewhere. And so you really want to be as conservative as possible with treating these in children as far as doing anything surgical. So preseptal cellulitis is an inflammatory infectious process that occurs. It can be from the hordeolum or chalasium going completely out of control. And since Hib vaccines have been out in the last 20 years or so, we see a lot less of preseptal cellulitis in kids, but they can still occur, and they're treated with antibiotics, and it can occur with adults as well. So antibiotic choice, there's a variety of options here. And again, it's going to be in your handout. If one of the rules in medicine that I've explained to patients, my partners, is the antibiotic of choice for an abscess is drainamycin. Okay. It's not going to go away. A pocket of pus is not going to go away on its own with antibiotics. It's got to be drained. And one of the other sayings I learned from an infectious disease specialist quite a long time ago is, don't let the sun set on pus. There's no purpose served in delaying treatment. You want to get it opened, and you want to get it drained, because they're not going to get better until that happens. So, and this is another one. Again, I've been seeing a slew of these in recent months, it seems, where people have been ignoring their chronic nasolacrimal duct obstructions, and they end up getting acute dacrous cystitis problems with abscesses that extend elsewhere. And you explain to this patient, after they've been drained, that they need to have a DCR, and the other side is blocked as well. And they say, what do I need to do to avoid this from happening again? And they say, surgeon, they say, sign me up. They don't want to go through this again. Anyway, moving along here, inflammation, allergy, inflammatory conditions of the skin, rosacea, and it's a common chronic adult-like acne process with facial erythema, telangiectasias, papules and pustules. Anything that makes the skin warm, whether it's alcohol, spicy foods, hot weather, sun, will cause an exacerbation. It's genetic in part, it's hereditary, and treatment with intense pulse light treatments can help, but it does tend to want to come back, and there's topical treatments and can be done. There's a patient that we did intense pulse light treatments on, and can make a dramatic difference for them. Blepharitis, again, you guys live and breathe it. Talking about this at length is like preaching to the choir, so we don't need to spend much time on that. Atopic dermatitis, it's allergic inflammatory process where in severe forms it can cause thickening of the skin. And the goal here is, finding out what the offending stimulus is in their lives and eradicating it. And for patients, I send patients to there are certain dermatologists who are more inclined to specialize in actual dermatology instead of just the world of cosmetics anymore. And so finding someone who will do the more aggressive treatments, and a lot of these patients do need to go on and see an allergist. One concept that's really important for any allergic process is encouraging patients to take their showers before bedtime and climbing in clean sheets instead of taking all the pollens and whatever it is they're sensitive to into their bed and pillows at night and wallowing around that for 6 to 8 hours. Allergies can be due to stuff that we do. Can be from, like this patient here, an allergy to bromonidine, and I'd have to ask Dr. Breek how common that is. I mean, statistics on that, any idea? But it's one of the most common ones. Yeah, bromonidine is one of the biggest culprits that we'll see this on. So eyelid edema in general can be due to a variety of things: inflammatory, systemic things with regard to thyroid, kidney issues, heart failure, and infectious processes like we've already seen, bacterial and viral. And then medication-wise, with regard to some immunomodulators, and that's far less common though. Graves' disease will, in the active inflammatory stage, will oftentimes see swelling of their eyelids, and they can have what's called pretibial myxedema. There are patients where they'll get skin changes after significant inflammation, whether it's an infection or any inflammation. You can develop pigment as a healing response. So that's post-inflammatory hyperpigmentation that we can see. Oops, meant to get rid of this slide because this isn't something that you'll commonly see. That'll be in your handout. Infiltrative lesions, the most common one that we're all going to be seeing are the xanthelasmas, and these are lipid-laden macrophages. The vast majority of patients have normal lipid profile. I wouldn't bother remotely getting cholesterol levels in patients who have this unless, say, they're like under the age of 30 or so, because it just happens. It's very uncommon that it's associated with an elevated serum cholesterol. These are completely cosmetic. The world of insurance companies says these are identifiable just looking at them. You don't need to necessarily biopsy them, and we are not going to pay. I have patients where we remove these on a cosmetic basis, but they can recur. Age-related involutional processes can occur slow over time, and those are listed here. Sun exposure is the biggest issue that will cause the malignant processes, and we'll try to get to that more quickly. UV exposure damages collagen, creates things that make my cosmetic treatment world a lot bigger and increase the risk for skin cancers. Let's move on to the most important area here, benign and malignant lesion processes. So on the benign, in the world of benign lesions, the most common one that we'll see are seborrheic keratoses. And seborrheic keratoses are kind of like a button that's got an irregular surface that's stuck to the surface of the skin, and they can be non-pigmented or pigmented, and they'll oftentimes have a greasy looking surface, and the treatment there is excision. Now, this here looks somewhat similar to that. This has a little bit more of a roughened appearance, but look through here, you'll see that there are eyelashes growing through. That's a telltale sign that this is a lot less likely to be a malignant lesion, and that actually is a seborrheic keratosis. But obviously it's getting to be the size of King Kong, and it would be nice for it to be not there. Again, seborrheic keratosis, medium pigmentation, irregular, slightly greasy looking appearance, that's benign.
So these lesions that are pretty clearly benign, will insurance companies still pay for you to remove them?
So so yes, they will. The rule is if it's causing irritation, if it's growing, a growing lesion, the world of insurance understands the concept that it is far simpler to remove something this big than wait till it's twice or 3 times the size, and now it's a trip to an operating room. So they will play ball as long as we can have documentation based on the patient's description that this thing is growing. So good question. Squamous papillomas, they're going to be well circumscribed. This is kind of the stalactite, or on the bottom of the stalagmite, that is soft and rubbery. And if it's irritating, if it's growing, yeah, we get rid of it. Viral papillomas are a whole separate deal here. These, oftentimes the patient says, 5 years ago I had 1, 2 years ago I had 2, and all of a sudden I got 50 of them. So if we see these, what we'll do is a staged excision, and the rule is you want to get rid of all of them because there's no purpose served in getting rid of just one because the rest are still going to be there. So I'm sorry? What virus? Oh, I can't remember the name. It might be HPV. I don't recall specifically, but it's just good to get rid of them. So you got to get rid of them all. Cutaneous horn. This is an important one. So again, it's in red. That means it's important. So it's like the stalactite, stalagmite, except it's firm. It looks like a rhinoceros horn here. And statistically, about 1 out of 50 of these is going to have a squamous cell skin cancer at the base. So those do need to be removed. Actinic keratoses are precancers, and they need to be treated topically to help prevent the progression into a true skin cancer. And the dermatologists will be walking around their offices with cans of liquid nitrogen, spraying things left and right. We have something similar in the office for those patients where it's on the eyelid, because you can't spray liquid nitrogen right on someone's eyelid. This patient was referred to me with a concern that they had a skin cancer here. And if you look carefully up close, you'll see that this actually is just a keratin cyst with a kind of a black head that's not quite black. And if you squeeze on that, all kinds of oily keratinaceous material comes up and out. This one here, it's well circumscribed. It's got firm, it's very firm, but it doesn't have firmness that extends beyond the edges. This is a water balloon filled with keratin and yucky stuff. And you can see the eyelashes are normal. It's just creating a mass effect there. Eyelid cysts, again, this is firm, but the firmness doesn't extend beyond the edges. It's just, imagine you've got a big pocket of junk underneath there. It's full of oily material. And here she is after doing a little flap excision. Comedones are blackheads and just little pockets of oils and keratin that just haven't been able to get to the skin surface. So moving along here, you look at this carefully and it looks very ominous. It's elevated, it's dark, but it's full of actually cystic material that's oxidized and turned dark. And so again, cysts, think again, water balloon full of white, yellow, keratin, just a pocket of material, and those were removed. Syringomas are an overgrowth of eccrine sweat glands, and totally benign, annoying, and the treatment for these is to excise them, but it's something that if they really care about, you want to remove the larger ones and try and fight the battles that are important and not overdo it. And again, the main reason to treat this is cosmesis. You can do CO2. Sometimes I'll do CO2 lasering for them if it's important, if their skin type is that they've got a lighter skin complexion, because CO2 lasers trichloroacetic acid peels will cause the skin to be lighter if you do it aggressively. Again, you look at this bump here, there are eyelashes growing up and out through it. Okay, we don't have loss of lashes. The firmness is circumscribed. It's not, the firmness isn't extending beyond the edges, but the fact that we have eyelashes growing up and out through this is a telltale sign that this is extremely unlikely that it's going to be anything malignant. You can see the same concept here. So remember, loss of lashes is a bad thing, but when they're growing up and through, less reason to be concerned. On the other hand, I bet this would show up in one of Dr. Parik's visual field analyses as loss of peripheral field. So, so they can mimic an early basal cell. And one of the challenges I get is I'll get patients who come to see me with a small bump. When things are small, it's oftentimes very difficult to tell what it is. So sometimes we'll say, well, let's just watch it, or we do a biopsy. This one I meant to get rid of because that's, you'll see one of these in your career if you're lucky. Congenital nevus, it's a mole that occurs at the lid margin before they separate. And these, if they're large, they can block the vision. You remove them. The concern, though, is that the eyelash follicles may be misdirected and they end up requiring a lot of electrolysis treatments. Again, non-pigmented mole. So lendigo simplex, that's just basically that is a freckle, and they are oftentimes will respond to superficial skin treatments. Nothing to be concerned about. The ones that we do get concerned about are things that are variably pigmented, changing where it's growing. The pigmentation is changing. It's not well circumscribed. You know, this is not discrete. This is not a, even if you look at one of these things here, it's discrete versus this, which has irregular borders. So lendigo malignans is a pre-melanoma, and we like to get rid of those. A lendigo maligna is basically a melanoma in situ, and we have to do aggressive excisions for those. This is the real deal. It's a malignant melanoma with, they oftentimes will have accessory satellite type areas surrounding them. And this is important to be wide excision. This patient had to remove their entire upper eyelid and make them a new one and involve a head and neck surgeon because we needed to do a sentinel node dissection, and it gets really complex because it's important to take care of these because this can kill you. Basal cell skin cancers. This is the most common skin cancer that we see anywhere in the body. And oftentimes, you know, this is breaking the rules a little bit as far as what I said before about it. The firmness doesn't extend beyond, but what is missing from this picture? Eyelashes. There are no eyelashes here. Anytime you have a loss of lashes, you need to raise your level of concern significantly. And then we have things like this, which didn't just start yesterday, and that's the other extreme. So basal cell skin cancers, again, it's the most common eyelid malignancy, and lower lid is far more common than the upper. Medial lateral cancer is more common than the lateral, and they just grow slowly where they occur. Metastases of these is almost unheard of. And excision is the main treatment for a patient like this here. Technically, oral treatment with ismodegib might be an option if they don't have a lot of other issues. But again, that's an extremely rare situation. We don't want to waste time on that. So this is a scary kind of thing where you look at this and go, someone with a dark complexion, pigmented spot, big deal. But the most important question, how long has this been there? If it's been there 20 years, we're not going to worry about it so much if it's unchanged. But when this patient tells me, you know what, this wasn't there 4 months ago, that makes me concerned. I do the biopsy and it turned out to be positive. So this is the patient immediately during surgery removing, making sure the margins are clear. and then sewing back together here. And here's the patient 2 weeks after surgery. And generally these patients, if it's small, 6 months later, you can hardly tell anything was done. Basal cell
So,
nevus
so
syndrome.
that patient, was that like a two-step procedure where you did the biopsy to first figure out it was a basal cell and then you did the wider excision, or was that all one procedure?
Yeah, good question. So this one I was concerned it was going to be a pigmented malignancy, and I was surprised when it turned out to be a pigmented basal cell because they're very uncommon. So did the biopsy in the chair in the office, and then this was done in the operating room. And generally speaking, we don't think of people with dark complexions having a higher risk of of basal cell and squamous cell skin cancers. One of the worst basal cell skin cancers I ever saw was in someone with a really dark complexion. So common things are common, but once in a while, rare things do occur. Basal cell nevus syndrome, I meant to omit this slide. That's a completely different animal where people are prone to skin cancers. Keratoacanthoma, that's a rapidly growing skin process. It's technically not malignant, or maybe it is a form of squamous cell cancer in situ, but they're very uncommon. So this is more of the commonly what we'll see with squamous cell skin cancer, where there's ulceration and irregularity there. And again, what's missing? Lashes. Okay, sebaceous hyperplasia are oil glands on steroids. It can be confused with basal cells because they can become umbilicated. They're oftentimes associated with rosacea. And sebaceous cell cancer, very rare, but when you get an elderly patient who has chronic chalasia, this kind of person, you might think, it's just a chalazion, and I might as well. But when they start getting progression into these other things, it's obviously a more significant issue. So it's a malignant transformation of sebaceous glands, and they can be very malignant and spread to lymph nodes. So those do need to be treated definitively. So this patient was referred to me. They had a big skin cancer in this area. And I said, let's involve the most people, because I was trying to spare their lacrimal gland, their lacrimal drainage apparatus. And so they got sent to me back with this hole here, and it actually was down to bone. And I was making these slides, and my wife is sitting next to me. She goes, I said, so what do you do to fix that? She goes, well, don't you just put a skin graft over that? I said, well, if it were superficial, maybe, but no, because you can't put skin grafts right on bone. I mean, you can in the face, but the problem is that it'll be very thin and uncomfortable. And so this is one of those situations where you move things around. I said, yep. So here's the excision, and we did a transposition flap from between the brows, angling that in, and then we need to mobilize skin from over here and pull that up and in, and then do a little baby skin graft over there. There she is immediately on the table, and here she is, I think it was about 4 months later. Thank you. And so there we are, before, after. And so just because things get big doesn't mean that necessarily they have to be cosmetically disfiguring. The rule number 1 of skin cancer surgery is get it all out. Rule number 2 is get it all out. Rule number 3, you can probably guess, is also get it all out. Rule number 4 is put it back together so it works as well as possible. And rule number 5 is put it back together so it looks as good as possible. Unfortunately, with the bigger ones, sometimes 1, 2, and 3 get in the way of 4 and 5. But so we're going to go to the post test now. Unfortunately, I blew it and I gave away a couple of the things in there. So going back through again, now that you know some of the tricks of looking at these things, again, we'll go through these quickly. Eyelashes going through. So we're going to call this one benign, right? Benign. This one here, we're missing. We got some eyelashes growing near, but not. This one, I'm getting were to cut it out. And this one did turn out to be an atypical basal cell skin cancer. Next one here. Benign. This is a mole. Eyelashes are growing through it. If it doesn't bother them, it doesn't bother me. We're going to leave it alone. If it's growing, we're going to get rid of it. This one here I gave away. This was a malignant melanoma that required complete excision. Malignant. Yep. We have umbilication. We have loss of lashes. We have destruction of normal architecture. Benign or malignant? The group here is saying benign. It is. This is a seborrheic keratosis. And again, if it doesn't bother them, sometimes these just get irritated. People, I think, tend to pick at them, play with them. They sometimes will flake off. And so oftentimes we'll remove these. If it's growing, yeah, just like anything, you want to take care of little problems and not have big ones. This one I gave away. I didn't mean to. This is it's called a hematic cyst, and there's actually it's a cyst that bled into itself, and then the hemoglobin breaks down into hemosiderin, and this is what's underneath there. So that's benign. I gave this one away. We have normal lashes growing up around, well circumscribed. We don't have induration, firmness extending beyond. That's just a big clump of oily, yucky stuff inside there. But we get rid of it because it's weighing down, being irritating. The group here is saying benign. You sure? But they were there for something else. They were thinking, well, there's a surgical gap. This is actually just a nasty big seborrheic keratosis. And yeah, the surgical cap sign was because they were having something else done. This was an incidental. But to get rid of that is going to create a big wound. And if it doesn't bother them, it doesn't bother me. This one here, this was a pyogenic granuloma growing up from a blocked meibomian gland and chalazion.
Quite a few years have the 2020 sign.
Yes. Yeah. All right. Benign or malignant? Yeah. So this one has, it almost looks like there's an ulceration here, and it does look firm, which it is. There isn't any surrounding inflammation to make us think it's infectious. There's no, the firmness doesn't extend beyond. And this one actually is just a big comedone. I squeezed this and all this yucky gunk just came squirting right out of here. No. Yeah, it looks suspicious. And I just said to the patient, well, let's give it a squeeze. And there it came. So I said, I don't know that I say that to all my patients. Anyway, this one here, benign. See, now you guys are thinking I'm overpaid. This is just a benign seborrheic keratosis. Actually, I gave it away. I showed that one. This is that pigmented basal cell I showed. Yeah, it looks like a basal cell, right? No, you probably, none of us may have seen it. I see these once in a while, but the rest of you, just because I'm at the bottom of a funnel. And this one here, benign, what is it? It's just a papilloma. And this one here, so it's got an indentation. It's got the belly button indentation. This one I wasn't sure on. And then I looked all over and there were a lot more of these. This is sebaceous hyperplasia. If you see one of these all by itself, yeah, I'm going to biopsy that. When I see that they're scattered all over the face and there's no ulcerations, there's no bleeding. But again, the only one who knows for sure is a pathologist. And Yeah, this one we're going to biopsy because it's a cutaneous horn. Remember, it looks like a rhinoceros horn, hard, and we're going to biopsy because there could be a squamous cell skin cancer at the base. And that's it on time. And Cope said it couldn't be done. All right, so questions. And again, if anyone has patients they just want quick curbsides on, feel free to